Welcome to the Roundtable of Internal Medicine. This roundtable will be chaired by the respectable Assistant Professor Dr. Konstantinos Ekmekjoglou, gastrointestinal at EUC. Now I will give the floor to Dr. Ekmekjoglou.
Hi, good morning to everyone. Welcome. It is my pleasure to welcome you. Hi, good morning. Nice to have you all with us. It is a pleasure to welcome you to the 5th Cyprus Annual Medical Student Meeting. A student which is done by you for you. We're really proud that we have set up this meeting. And now in the aftermath of the pandemic, that we learn to go with our lives as we did the years before the pandemic. For 2 or 3 years, at the beginning, most conferences were cancelled. Then we went into an online module. Then we did a hybrid module where the presenters were presenting and most of the audience were at home. But I think now that we can look back at the pandemic with a nice, more clear view, all conferences should be held as we do now, with physical presences of the presenters and the audience. So I would like to thank the organizing committee, especially Valerie and Rotem and Daniel, which I know for some years now. I have the honor to be the first chair of the first roundtable presentation, and we'll be discussing diseases of the valves of the heart. And without further ado, my first colleague who will come to make her presentation is Vasiliki Sakelariou.
Hello, good morning to everyone. We're the team of internal medicine, and as Professor Ekmekjoglou already said, we're discussing diseases of the heart valves. So, I'm going to present firstly by starting with basic anatomy of the heart, and then we're going to explain how the structure of the heart is helpful for the physiologic mechanisms for blood circulation. Then I'm going to move on with basic anatomy of aortic valves, and then we're going to discuss a case scenario to go further and explain aortic stenosis. So, the heart is made out of cardiac muscle and has 4 chambers, 2 atria, the left and the right atrium as you can see, and 2 ventricles, the left and the right one as well. There are also 4 valves, where the blood comes through and gets pushed through the organs. And let's go through the physiology. The blood that contains carbon dioxide from the organs goes to the right atrium through the superior and inferior vena cava, and then passing through the tricuspid valve, it reaches the right ventricle. Then through the right ventricle, it gets pumped to the lungs, through the pulmonary semilunar valve and passes through the 2 pulmonary arteries. And when it reaches the lungs, we have the exchange of the gases, where the blood leaves the carbon dioxide and gets the oxygen. Now, the oxygenated blood from the lungs returns back to the heart, to the left atrium more specifically, through the pulmonary veins. And then, passing through the bicuspid or mitral valve, it gets to the left ventricle. And through there, and by getting pushed through the aortic valve and the aorta, it reaches the systemic circulation and then the organs where they get oxygenated. Going into further detail, we're going to talk about the aortic valve. It is located between the left ventricle and the aorta. It is a semilunar valve, meaning it has a half-moon-like shape, and it has 3 cusps or leaflets, which are helpful to open and close during the blood passing through. Now we have a case scenario. Let's say a 70-year-old male comes to the ER and has the following symptoms: a severe chest pain that we're going to name angina. It's very tired, especially after engaging with exercise, has shortness of breath and dyspnea, and very severe heart palpitations. Going through the physical exam, during auscultation, we hear a weird swooshing sound that is named murmur. So because of those findings and those symptoms, we're going into further examination and we're ordering an ultrasound. You have here the normal one for comparison. And here you can see on the right side the aortic valve, which the lumen is very narrow and the blood cannot pass through. So we call it aortic stenosis. And for further explanation, we also get an ECG. That's the normal one. And here is the one from our patient who has an aortic stenosis, where the airway is enlarged. And we also have an ST depression and an inverted T wave. So the disease we're referring to is the aortic stenosis. You can see here the normal versus the pathologic one. The epidemiology. Aortic stenosis is showcased mostly in patients who are aged between 65 to 75 years old, with a percentage of 29%. And when it comes to North America and Europe, the etiology is mostly the calcific stenosis, while when referring to developing countries, the etiology is mostly the rheumatic valve disease. And going into the pathophysiology of the disease, here you can see the aortic stenosis. The aortic valve basically gets calcified, which is either due to congenital reasons, it might be age-related, or due to the rheumatic fever. And due to the calcification, it gets rigid, and the leaflets cannot move that well, so the movement gets restricted. That leads to the lumen becoming narrower, and due to that, the blood cannot get pushed through it with the same, as easy as it could be when it was at the normal state. So the left ventricle, which is connected, starts pushing blood with greater force, which leads to it becoming hypertrophied, as it is a muscle. And while the time goes by, due to this constant overworking of the left ventricle, it starts getting dilated, and so the muscle starts losing its function. It becomes thinner and thinner and constantly loses function. So what we have to do is to give to our patients some treatment. And we can start by treating the symptoms, where we use medications such as statins, beta blockers, nitrates, calcium blockers, ACE inhibitors, diuretics, and digoxin. And we can either choose one of them based on the symptoms or use a combo. We're doing personalized medicine. We also have the option of an aortic valve repair. And we can use an aortic valve replacement, where a mechanical valve or a tissue valve gets shown in place instead of the calcified valve, and the pathologic gets removed, and it basically does the same job. We can also do a balloon valvuloplasty to help with to offer some relief to a patient, but this procedure unfortunately doesn't work for a long time because the aortic valve becomes once again calcified. And lastly, but not least, we can also have a transcatheter aortic valve replacement, where we use a catheter which we pass through either the femoral artery, the subclavian, or even the aorta in order to reach to the pathologic part of the heart. And once again, we use a catheter with a balloon to replace the valve. And now we're going to proceed with my colleague. Thank you.
Good morning, everyone. I'm Eleni Vosmamai, and I'm third-year medical student, and I'm going to proceed with the aortic valve regurgitation. So I'm going to talk about the normal anatomy briefly, because Vasiliki mentioned it, the aortic valve regurgitation, specifically what it is, the definition, the normal and the diseased valve, the epidemiology, the causes of the disease, the symptoms that it may show, the diagnosis, what are the complications of the disease, what's the treatment, and my personal favorite, the lifestyle changes and the prevention. So the normal anatomy, as we already mentioned, we have the heart, has 4 chambers and 4 valves that they open widely and let the blood pass through. And when the blood has passed, they shut tightly until the next heartbeat. Here is the anatomy in a more specific picture, and here is actually the aortic valve that we're interested in now. And it's located between the left ventricle and the aorta. About the definition, the aortic regurgitation may sound a little complicated to your ears, but it's actually the insufficiency of the aortic valve. It's a valve that doesn't do its work well. It's actually the inadequate closure of the aortic valve's leaflets or cusps, as we call them, which allows some blood that was pumped out of the left ventricle into the aorta to leak back in. So we see here the normal condition. The blood is pumped into the aorta, and there's no leakage, there's nothing on the left ventricle. And here is the blood pumped into the aorta, and we have a leakage of blood going back to the left ventricle. So here is the normal anatomy of the valve. The valve is tricuspid, which means that it has 3 cusps that they close tightly and they open widely, as it shows here. Here is the diseased valve, and we see that the cusps are a little fused, and they can't close tightly as they have to, and they can't open as wide as they are supposed to. So, about the epidemiology, more men are affected compared to women. The prevalence of aortic regurgitation is increased with age. Mostly the patients are 50-year-old and above. It's a little bit higher in the United States, and about 4.9% to 10%, and in Europe it's 1 to 3%. So about the etiology, what actually causes the disease? How is it possible to happen? So some people are born with a different structure of the valve. It's the congenital heart valve disease. The valve is called bicuspid because it has 2 cusps as shown here instead of 3, which is the normal one. Other people are born with a cusp with 1 leaflet, 1 cusp, and it's called unicuspid valve. It looks like they are 3, but they are not actually separated. It's not cut here. So it's 1 leaflet that tries to open and close widely and close tightly, which is a little hard to happen. So another cause might be aortic stenosis, as Vasiliki mentioned before, due to calcification deposits, as we see here, that don't allow the valve to close as supposed to. Endocarditis, which is the inflammation of the lining of the heart that could inflame the chamber as well and the valves. Rheumatic fever is not that common, but it has a high prevalence in children because it starts with a strep throat and it gradually developing the rheumatic fever, as we see here. There's a young patient. Other conditions that may cause the disease is Marfan syndrome. Marfan syndrome, the symptoms, like how this patient comes to our office and what are the possible symptoms, what we will see. Most of the times we see nothing, and the patient has nothing like any disability or discomfort because this disease develops gradually during the years. But we may have the acute form of the aortic regurgitation due to an infection that triggered it or iatrogenic reasons. So in that case, we have the shortness of breath or dyspnea. The patient may be fatigued or weak. The patients may have the sensation of their pulse. They will feel in their pulse, called palpitation, angina, chest pain, and swollen ankles and feet due to edema. How we can diagnose now these patients? We start with the basics. Physical examination is it's an examination that a lot of doctors can perform with their stethoscope. It's very easy, and it's not very specific. That the thing that we make here is the aortic regurgitation, but under auscultation, we will hear a murmur at the area of the left lower sternal border, around the third and fourth intercostal space, that we have to investigate further. We're continuing with chest X-ray, which is actually show us a little abnormal silhouette of the heart and mediastinal, as you see here. Our heart is a little large, and we can easily identify the aortic dilation up here in the mediastinal. And let's see what are the abnormalities in this specific one. So here is the hypertrophy, and actually it's the hypertrophy of the left ventricle, and the aortic dilation shown. We have, of course, ECG, which is a very important part of the diagnosis, even though it's non-specific. The findings we have are non-specific. We have findings of left ventricular hypertrophy that, again, leads to further investigation. The things that I want to pinpoint here, because we're not experts on ECGs, but we can see the increased QRS complex voltage in the precordial chest leads here. They are very visible compared to the normal one, that they are shorter. We also have an abnormality of the T wave, as the arrows indicate, that they are going down. So, transthoracic echocardiography is maybe the golden standard of diagnosing aortic regurgitation. Is very sensitive, very specific, an accurate test for aortic regurgitation. Here we see this mosaic of colors that actually indicates the ventricular outflow, and the mosaic actually means the turbulent volume of the blood, the turbulent flow, excuse me. We also have cardiac catheterization that we insert in the catheter through the groin or the arm, from the femoral or the subclavian artery, under IV and anesthetic. And it's also very, very important diagnostic method to assess the severity of the aortic regurgitation, to assess the left ventricular function and the root size. And the last one is the aortic angiography, which is happening under the cardiac catheterization, during the cardiac catheterization procedure. And it would provide useful information, again, for the severity of the disease. What are the complications now? I have aortic regurgitation, and then what? What is happening? So, aortic regurgitation may cause left ventricular systolic dysfunction and hypertrophy, because we have a ventricle which tries to pump blood like more than it used to, because when it pumps the blood, it comes back and then trying again, and the ventricle got weakened and hypertrophic. This leads to congestive heart failure. It could lead to ischemic cardiopathy, to many arrhythmias, and even sudden death. But after surgical treatment, all these complications can be gone completely. So the treatment could be pharmaceutical through medications, and in that case, we're not actually treating the aortic regurgitation, but we treat the symptoms. And most specifically, we're treating the high blood pressure. With, we mainly use ACE inhibitors, ARBs, and that act on the angiotensin, and loop diuretics for the edema. About the more invasive procedures, we have the aortic valve repair. It's like your grandma used to knit your ripped sweater, ripped pullover. Like that, we are patching holes on the valve with extra tissue, or we are remove the excess valve tissue in order for the valve to close tightly, as we see here. And last but not least, we have the aortic valve replacement. We used to do it with a big incision in the thorax and open a window to the heart, but now this has changed. In some patients, we can perform the transcatheter aortic valve replacement, which is of minimal invasion. And we're replacing the valve with a mechanical one or a valve from a cow, pig, or human. It's interesting to mention that we could replace the aortic valve with a pulmonary valve, but then the pulmonary has to be replaced with lung tissue or a valve of a deceased patient. And about the prevention and lifestyle changes that we all can do, we have to stay in a healthy way. It's very important to keep a balanced diet, a Mediterranean one, to exercise, to quit smoking or avoid it, managing our blood pressure, early infection treatment, so we have to do regular monitoring by our healthcare professionals. So that is all, and stage is yours, Ray.
Hello, good morning, everyone. I will talk to you about the mitral valve. I'll start off with the anatomy of the mitral valve and the mitral valve function in the heart and what is mitral valve regurgitation. So as mentioned previously, that's the anatomy of the mitral valve. It's located between the left atrium and the left ventricle. It contains 2 leaflets. So the mitral valve function, during diastole, the mitral valve opens, allowing oxygenated blood to pass from the left atrium to the left ventricle. And during systole, the mitral valve shuts, preventing the backflow of blood. So when the backflow happens, that's called mitral valve regurgitation. And mitral valve regurgitation occurs due to the insufficiency in the mitral valve function, leading to incomplete closure during systole. What's the most common mitral valve regurgitation? That would be the mitral valve prolapse, where in the mitral valve prolapse, the connective tissue of the leaflet and the surrounding tissue is weakened, which is also known as the myxomatous degeneration. And as you can see here, the one on the left, that's the normal. You can see that there's pressure applied on the mitral valve during systole, which is normal. And on the right side, you can see that the mitral valve it flops back inside the atrium, which is bad. Anyway, the myxomatous degeneration, or the mitral valve prolapse, patients are usually asymptomatic but present with a classical heart murmur with a mid-systolic click. This click is, as I mentioned previously, is the leaflet being forced back up to the atrium due to the systolic pressure in the left ventricle. Also, fun fact, you can also hear the mid-systolic click while the patient is squatting. You can hear that the click is closer to the S2 phase, and the murmuring duration is shortened. And on the contrary, you can also hear the mid-systolic click while the patient is standing. You can hear that the click is closer to the S1 phase, which means that the murmuring duration is prolonged. Why? This happens because squatting increases the venous return, so the leaflet gets forced up during the contraction due to the extreme overfilling of the left ventricle. And on the right side, this happens because standing decreases the venous return, so the leaflet gets forced up earlier during the contraction due to the emptiness of the left ventricle. Mitral valve regurgitation, other than myxomatous degeneration causing mitral valve regurgitation, we can also name a few more, like damage to the papillary muscle by heart attack. Damage to the papillary muscle by heart attack can actually kill the papillary muscle, can cause death to the papillary muscle, making it loose, which anchors the which anchors the tendon that holds the leaflet, which ends up causing the leaflet being loose. Anyway, we can move on to the left-sided heart failure. The left-sided heart failure leads to ventricular dilation or left ventricle hypertrophy. This happens, this causes actually the mitral valve regurgitation, because when there's left ventricle hypertrophy, it stretches out the leaflet and the mitral valve, which leads to backflow due to inability to fully close. And finally, the rheumatic fever, as mentioned before by Eleni. The rheumatic fever is an inflammatory disease that affects the heart tissue, which leads to chronic rheumatic heart disease, which eventually leads to leaflet fibrosis. So yes, as I mentioned previously, the left-sided heart failure. Left-sided heart failure leads to left ventricle hypertrophy. And when the left ventricle dilates, it pulls the leaflet apart, creating an opening which allows the backflow of blood, which eventually leads to mitral valve regurgitation. Can mitral valve regurgitation cause left-sided heart failure, which is vice versa? Actually, yes, it can. You might ask how this can happen. With every left ventricle contraction, which is systole, some blood is pumped back up to the left atrium, which is backflow. This leads to increased preload, volume overload in both left ventricle and the left atrium. So the heart goes through eccentric hypertrophy as a compensation mechanism to manage the excess volume. This is an X-ray of the normal chest compared to the left ventricle hypertrophy, which is actually not so clear. So that's a more like specific. It's more clarified, actually. Yeah. Anyway, so you can see that on the green area here, that's an enlarged silhouette of the heart, right? And those butterfly-like consolidation, that's actually pulmonary edema, which can be treated later by diuretics. Anyway, I'm gonna move on to diagnostics. We can start by echocardiography, which, as mentioned previously by Eleni, transthoracic echocardiography, which is the golden choice for mitral regurgitation assessment. Then we have the lab findings, where we check for troponin, and if troponin is elevated, this may indicate that myocardial ischemia has occurred. And we can also check for the BNP. It may be normal in acute mitral regurgitation. It may be normal in acute mitral regurgitation, and BNP elevates as the severity of mitral regurgitation increases. We can also check for blood cultures in suspected endocarditis in not less than 3 trials. And the ECG. ECG findings are mostly non-specific for acute mitral regurgitation. It can show a normal sinus rhythm. It can show a sinus tachycardia with non-specific ST and T wave abnormalities, which you can see it here on the top right side. And we move on for the ECG for the chronic mitral regurgitation. It can show left ventricle hypertrophy. It can show left ventricle hypertrophy as you've seen before in the chest X-ray. You didn't see the chest X-ray, did you? Anyway, yeah, yes, you can identify the ventricle hypertrophy on the ECG by the elevation here in lead V6. Anyway, and the P mitral, which is the prolongation of the P wave, which can be classified by the biphasic P wave, or the prolongation of the P wave more than 10 milliseconds. Wait. Where is it? There was supposed to be a treatment somewhere. But anyway, yeah, it was supposed to be there, but that's fine. Anyway, so what's supposed to be in the treatment is basically that all patients with mitral regurgitation, acute or chronic, they should undergo surgery for definitive treatment, right? And during the time that the patients are waiting for surgery, you could manage their symptoms you can manage the symptoms before heart failure, right, by giving nitroprusside, nitrates, and diuretics. And surgery, the procedure is valve repair. It's the most preferred option because of the reduced risk of mortality and complications. Anyway, thank you. And if you have any questions, please ask us.
So I would like to thank all the three presenters for their excellent presentations. Take a deep breath. The hard part is over. I know this was your first introduction to how we give a presentation to a large audience. Remember, there are guys watching us from home. Okay, so now you're not virgins anymore. So please relax. And do we have any questions from the audience? None? I know they were excellent, but do we have any questions? Does anyone want to add something before I start questions? Okay, so the first topic was about aortic stenosis, right? Excellent. So just to set the record straight and not let the audience being misled, what are the main findings in a patient with aortic stenosis? You had a patient coming to the ER saying, and you said that this patient had aortic stenosis. What are the main findings?
Okay. So basically, the patient came because of his angina.
Okay.
He had a severe chest pain. So that was a severe sign that we had to check further. And then we had palpitations that we thought it has to do with something cardiovascular, and that's what led us to think about stenosis, as well as the murmur during the physical exam.
So don't forget, patients with that much serious aortic stenosis have signs of either dyspnea or angina or any kind of syncope that should be looked upon. Excellent. Do those, and this question goes to all of you, do those heart valve anomalies have specific ECG signs? Because you all shown ECG signs,
yeah.
so
Yeah.
can we make a diagnosis of something going wrong with the heart valve from an ECG?
Actually, the ECGs are non-specific, but they are giving us signs about ventricular hypertrophies, atrial hypertrophies, so we're going into further investigation.
Excellent. So I completely agree with what Ms. Mama is saying, okay? ECG findings in patients with severe or less severe valvular problems are not characteristic, okay? So you get indirect info from what the patient has, okay? Maybe he has signs of chronic failure. maybe has signs of a STEMI or a non-STEMI, which can be with those kind of valvular abnormalities. So please pay attention, because you will get these patients all over the world. I'm 47, maybe I have some kind of small mitral regurgitation. Who knows? I've never checked I've never done so again, so signs are non-specific. Excellent. ECG signs, something. I remember, I think it was Ms. Mamai who told us about angiography, right?
Yeah.
Okay. Do we regularly do angiography to assess the severity of any kind of cardiac valvular abnormality?
Actually, if we have like signs from more basic examination like ECG or X-ray, we're getting into more specific examinations like angiography. Actually, is one of the standard ones for the aortic valve regurgitation, because it shows the severity of the disease, the exact level.
So let's pretend I have aortic valve regurgitation. You would do the ECG, you would do the clinical exam, and then you will send me for an angiography?
Yeah, it depends on the symptoms, on the severity of your regurgitation.
Okay.
I think.
Would you consider doing an echocardiogram first?
Yes,
okay.
yes.
So the main thing I need for all of you to get the nice message out there, okay, so that invasive procedures are the last resort for any kind of physician, okay? So nowadays with the 2D and the 3D dimensional echocardiography and the transthoracic and transesophageal echocardiography, we have pretty much a good knowledge of the degree of the severity, because one point is to have the clinical suspicion that your patient has some kind of valvular problem, okay? Maybe he has aortic stenosis, maybe he has mitral regurgitation. The second thing is we have to grade the severity of the stenosis or the regurgitation. And we do this by echocardiography, okay? Either transesophageal or transthoracic, okay? Nowadays, we have talented cardiologists which can grade us the severity of, for example, if you have an aortic stenosis, they measure the velocity of the blood going through the mitral valve. If it's getting less and less and less, then the severity of the aortic stenosis is more and more and more, okay? The same with regurgitation. The more amount of blood they see filling up the ventricle, they grade the stenosis more, the regurgitation more and more and more. Excellent. What about treatment? In which patients need valve replacement in general?
Any patient with valvular damage.
Any patient?
All patients with valvular insufficiency.
Okay. Do you agree?
I would say that first we're moving based on the symptoms of every patient and the age. If we have like a 50 or 60-year-old patient with severe symptoms of regurgitation or insufficiency and the valve like destroyed, we are moving on to replacement. Because it's a young patient, it's considered a young patient, and you know, physical activity, they have to live their life.
So surgical valve replacement is indicated for severe forms of either stenosis or regurgitations, okay? And only in selected patients. For example, you have a 95-year-old patient who has severe mitral regurgitation or aortic regurgitation. By all means, he most probably will never make it through putting a nice heart replacement. If we skip the stages where the valvular problems are that severe, what is the medical management? How do we treat these patients? What is the rationale between giving drugs, and Professor Zvitanova can help us in the audience. What is the rationale? I don't know. Even nicer for me. So you will know. You give me the right answer. So what is the rationale between giving drugs for these patients? What do we want to treat?
So basically, the medications we use in these cases are for symptomatic relief. It's not that we treat the disease. It's
Excellent.
basically to treat the edema,
Excellent.
the
So-
palpitations.
Those patients, especially patients with moderate or severe valvular problems, have signs of pulmonary edema, of congestive heart failure, of an acute myocardial infarction. So you have to deal with the symptoms, okay? So you have to reduce the preload. Maybe you have to reduce the afterload. I'm guessing you will hear about this in year number 4 when we go into cardiology. So your main task in giving drugs to this patient is to try to make the symptoms, okay, go down.
Yeah.
Yes.
So mostly,
Thank you.
the main symptom and the more severe that we want to treat, that we're trying to treat in those diseases, is the hypertension. So we're using antihypertensives, we use ACE inhibitors, ARBs, and we're using also diuretics for the edemas that may appear. Not together, of course, and not in pregnant women.
Okay. So I know you will go into cardiology and you will discuss it in year number 4. You go in year number 5 and you do molecular therapeutics. Well, you discuss all the medical management, which is really complex in patients like this. But remember, they're not unusual patients. You'll see these patients on an everyday clinical basis. Either you're a cardiologist or a GP or involved in telemedicine or in geriatrics. Most of your patients will be taking 1 or 2 or maybe 3 antihypertensive drugs, okay? Most of the patients will have some kind of cardiology consultations once over a while. So please make sure that you know what's the rationale behind giving drugs.
Yes.
I
I would like to also add to the previous questions that we also have to check any comorbidities from our patients, even when it comes to treatment or even if we decide to do a surgical procedure or not.
Excellent. I have 2 more questions and then we can end the session. I was wondering, do we give antibiotic prophylaxis in those patients? Because we're joined by the Department of Dentistry and we are also having dental students among us. So do those patients, which most of the patients under the age of 60 or 70 will have some kind of mild valvular problem, okay? Do those patients require antibiotic prophylaxis when they go for dental work? For dental work, yeah.
Actually, because of some diseases causes is endocarditis, and it's possible to happen from like germs coming from the dental procedures.
Yeah.
It's important to prevent those with antibiotics.
So would you cover with antibiotic prophylaxis all patients with some kind of valvular abnormality, either regurgitation or stenosis? Do we do that in our everyday practice? I don't know, we have dental students among us. Are there dental students? No. So let's say Loa has a moderate mild regurgitation and you are his dentist or his GP and he asks your advice. Should I get antibiotic prophylaxis before I do dental work?
Yeah, I would say yes, even if I'm not a dentist. I would say yes, because he may go under dental procedure, and this may affect the valves.
Any thoughts on that?
Yeah, I also agree, but we're going to use a mild, probably wide-spectrum antibiotic, just as a prophylaxis, as you said.
Anyone else from the audience has?
I think there's criteria for it. Not every valve disease has to. But if there's prosthetics.
So this is the main thing, okay, and this is what the audience should this is a take-home message. So most patients with some kind of valvular abnormality do not require antibiotic prophylaxis when they go to the dentist, okay? They only require if they have some kind of prosthetic part in their valves, or maybe if they had an episode of infective endocarditis in the past, okay? Because they are high-risk patients. So we would try to give some kind of antibiotic prophylaxis only to those patients. Otherwise, because, you know, most of your 67, again, I'm telling the odds because after the age of 50, 60, most of your patients will have even a small degree of mitral valve regurgitation or prolapse or stenosis. It's common, okay? So most of them will never require antibiotic prophylaxis, okay? And my last question, and it has to do with that, with the infective endocarditis. Now, do you know, can you understand the rationale between giving drugs for tonsillitis, for example, for giving antibiotics? Why do we give drugs for tonsillitis?
Because there's inflammation. No, to reduce inflammation.
Do you agree? Okay, so when we give drugs to a patient, when we offer treatment, it's because either the treatment reduces the severity of the symptoms, or we reduce the length of stay in a hospital, or we reduce the survival or the comorbidity, the mortality of the disease. But all studies have shown that tonsillitis will go away by its own. It will do a circle of 2 or 3 days with fever and blah, 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 and sore throat, and you have problem talking, but it will go away. You do not need antibiotics to treat tonsillitis. You give antibiotics because you want to prevent this sequela, which is mostly have to do with problems with the heart, okay, valvular problems, infective rheumatic fever, and problems with the kidney, okay? Any kind of glomerulonephritis that can be caused by the bacterium, okay? Any thoughts, anyone else from the audience who wants to dig into our little conversation? So if there's no other questions, I would like to thank our students so much for the excellent presentations. Thank you so much. You should have done all the questions about treatment, not me.
Thank you, everyone. Now we're going for a coffee break.
Congrats to everyone. Yes.
Her name is Mamai Bosch.
Bosch is which one? You use both? You use both?
It is with great pleasure that I welcome you to the roundtable of Maxillofacial bone grafting. This roundtable will be chaired by the respectable Dr. Panos Kesaris, that is the last person sitting at the table over there. That is an oral maxillofacial surgeon graduated by United States and the clinical supervisor at the UC Clinic. Now I will give the floor to Dr. Panos. You have to press.
I did, okay. Thank you very much. Thank you all for being around. I just want to say that this usually is a subject for postgraduate students, but your colleagues here, as undergraduates, took the challenge, took the risk, and to tell you the truth, they really overwhelmed me with their absolute and definite scientific presentation. They just went far beyond my expectations, and I think you will also be impressed by what they did. So my message for you all is that I really consider you as the smartest generation being so far on Earth, and since the science of the sciences, your science, our science, is the one that will really give solutions for the long living of the human species, just keep in mind that there's nothing that you cannot do, and never let anyone crush your dreams. So to the meaning of carpe diem, the Latin carpe diem, there is a much earlier ancient Greek saying which says "osso zis phenu," and the translation of this is "while you live, shine." The meaning of this is try to become better and better every day, doing the right thing as doctors and as humans. So I feel really proud of you all. I feel really proud of this team. Mike, Zaid, and Sima are my fifth-year students. I'll go by the year. Angeliana is my fourth-year student, and Daniel is my third-year student. I consider that you all have a special talent in here, and all you need to do is show respect to yourselves and to the others, just to become better and more truthful. So I hope you will all enjoy this presentation. I really enjoy it every time I see it, because we've been meeting for the last month's weekends, extracurricular hours and meetings, and every time they impress me. So enjoy this, and feel free to ask anything you like. Thank you for being here. Mike, you're first.
Have to connect it. It's okay. Can you give me a hand? Just for the notes, they don't show. Can you give me a hand? To put in presenter's mode.
One second. Sorry guys, 2 minutes.
Well, it took us 3 or 4 years to reestablish this, so I think we can wait another 2 minutes, right? Again, being an undergraduate means that you are in the beginning of learning all the basics. So one of these things is to learn how to make a presentation. Your colleagues here, they have the knowledge, they have the ability, but the experience of presenting without keeping in mind always what comes next on the slides of your PowerPoint shows, of course, an experience upon presentations, but also shows how good you are on knowing your subject. So whenever I started presenting as an undergraduate and later as a postgraduate student, the points from my mentors were just say and explain in a simple matter in a way that even someone who is not a doctor, but without leaving the scientific terms, to understand what you're trying to say. So it is normal to be stressed, it is normal to lose your words sometimes, but nobody was born like ready for this. So the more you practice, the more appreciative you will be about how things get better as a learning curve. And this goes to every subject that you're leaning on. So learning and delivering knowledge go together sometimes, and it all has to do with practice.
You want the notes?
Also, meanwhile, we wait. I want to give you a few points about your colleague's presentation. We have 5 parts. First part is about autologous grafts, autografts, where any kind of bone graft or other type of graft, but we're talking about bone structures, are taken from the patient himself. The allografts are taken from the second category, are taken as grafts from other patients, other humans. Either they are trauma patients, alive, or deceased, something that we find in bone banks. The third category has to do with xenografts, which really has to do with different species. Like bone, we use sometimes taken from pigs, from lambs, or bovine bones, cows. The fourth part talks about alloplastic grafts, which are synthetic grafts, grafts that are made in, let's say, factories, in special labs. And the fifth part, and last one, has to do with growth factors, meaning factors that really are really used in combination with the previous categories or alone to enhance the healing process. So all these 5 different categories by your 5 colleagues will be presented mainly on the clinical basis, because we know that you all might be bored with a lot of theoretical stuff. But the truth is that from research and theory comes our experience to do clinical applications. But then again, putting a little more of pictures from clinical cases will make it a little more interesting for you to understand how we use each type of graft and how we combine them in different cases. So if somebody asks you, so what is the best type of graft to use? You can just answer every type of graft is good depending on the case we are facing. It might be a golden standard, as it used to be, only the autologous graft, the one taken from the very same patient, or the combination of this type of graft, the autologous, with xenografts or with alloplastic grafts. So we evaluate each case in as a unique case, and we make it work the best way we can by using the less invasive technique. So back in the dinosaur times, when I was trained, we were using a lot of autologous grafts, meaning grafts taken from the cranium, from the hip, or elsewhere. As we become older and older and more experienced and more technology comes to our hands, we can understand that we can have the same results long-term by using less autologous grafts, meaning doing less surgery to our patients and using more of the other materials which can really be combined in a nice ways and give the same result. So as surgeons, we don't become better by doing larger surgeries. Can we start? Yeah, we can start. We're ready? So for those of you who will become surgeons, just think that being less aggressive and more gentle is what is going to make you become different and perhaps better as a surgeon. It's really important to understand what being gentle means for yourselves and to the patients. Are we set? Okay, let's roll.
And we have to start by the bone, which is the one and only tissue whose healing process includes the two remodeling phases of resorption and apposition, instead of the growth of fibrous connective tissue, usually happening with scars. The aim of the treatment of bone abnormalities is to fix abnormalities concerning the size, the shape, and the position of the bone. As we can see here, this is a case of hemifacial macrosomia. We can see the defects on the condyle and on the chin. And this is a case of Curzon syndrome, as you can see the defect around the orbit. What are the indications for using bone grafts? When we need mechanical support of surrounding tissues, when we need functional rehabilitation, and when we need to rehabilitate the aesthetics. The main advantage of using bone grafts is that it provides a matrix for reconstruction when we have viable cells. The phase of bone healing starts with the initiation phase, which is stimulated by local and systemic factors. Then we move to the resorption phase, which is the activation of osteoclasts, and we have an initial reduction in bone mass. And then we have the reconstruction phase, where mesenchymal cells of cancellous bone give rise to osteoblasts, which in turn are responsible for the calcification of the osteoid. What are the types of bone grafts? The autogenous grafts, also known as autologous grafts, the patient is the donor. For allogenous or homologous, the donor is of the same species. For heterogeneous grafts, also known as xenografts, the donor is of another species. We also have alloplastic grafts, which are completely synthetic grafts. We also have bone growth factors, such as BMP or PRP, and many combinations of all those together. I will elaborate more on the autologous grafts. The autogenous bone used to be considered for a long time the golden standard for bone grafting, but we're going to see together if this is true. It provides us with biocompatibility, which is the acceptance without host response, since it's derived from the hosts themselves. Also induction, which is the ability to generate bone. Also conduction, which is the ability of bone-forming cells in the graft area to migrate across a scaffold and replace it with newly formed bone. And also, it provides structural integrity. The donor sites, the most common ones are the posterior hip, where we harvest an endochondral graft, cranial, as we can see here, costochondral, which are harvested from the 4th to the 8th rib, mandibular, from the symphysis or the coronary process, as we can see here, and maxillary from the tuberosity or the zygoma, and carpal, tibial, or fibular. The types of autogenous grafts we can harvest are cortical, cancellous, or corticocancellous, which are usually harvested in the form of blocks. Now, regarding the revascularization, which is better? Cancellous grafts start with a positional bone formation and end with resorption, and this whole process is completed at 2 weeks. Cortical grafts start with resorption, and then they move to the appositional phase, which takes around 1 to 2 months, and the end result of the bone is a picture of necrotic and viable bone together. Regarding the strength, cortical grafts are 40 to 50% weaker than cancellous from the 6th week to the 6th month. The ideal autogenous graft should be a structure of a block graft and have osteogenic potential of particulate marrow. Osteogenesis of particulate marrow is quite difficult to achieve when one single donor site is used. Also, a large block of corticocancellous graft requires the removal of a large portion of the patient's anatomy, and still may not provide the high concentration of osteogenic cells commonly found in cancellous grafts. With what we know so far, can we say that the autogenous graft is the ideal graft? Almost, but we forget the most important factor and downside. According to Professor Dr. Birte Melsen, stability is post-mortem, meaning that it comes after death. When an organism is alive and they have something derived from a live organism, then this will continue to undergo remodeling throughout their lives. So we know that autologous grafts tend to resorb. Regarding cleft palates, cleft palate happens if the tissue that makes up the roof of the mouth does not join together completely during pregnancy. We tend to use autogenous graft for cleft palates, and usually they're harvested from the chin, and in the form of monocortical bone blocks, usually. Internal fixation of the graft is unnecessary and might interfere with canine eruption, so they're just placed there with a wedge principle. The area of the chin can be reharvested again after 5 months to gain a new graft. It's a relatively easy and safe procedure. There is high patient acceptance and high concentration of promoter proteins in the area. This is a case of Dr. Kesaris with a cleft palate. We can see here the defect. And also here, if you take a closer look behind the bridge, you can see the defect on the soft tissue. In this case, the bridge was removed, and an anterior hip graft was taken in order to reconstruct the maxilla. Now we'll show a case of a cranial autologous graft. This is our case, great maxillary defect. We can see it clinically. We can also see it on the cast. This is also the X-ray. And for this case, a graft was harvested from the cranium. The 2 pieces of the graft were attached together, fixated together with screws, and placed in the maxilla. Those are the soft tissues after healing of the graft. This is during the implant placement, and this is the final X-ray with the implants in place. And those are the prostheses, the occlusal view and the frontal view. Thank you very much.
Okay, hi everyone. So thank you, Mike, for the introduction. And now I'm going to continue on allogenic bone grafts. So let's get started. Allogenic bone grafts are basically donor bones that come from a different human specimen. It comes in grains. Thank you. comes in grain, paste, or complete bones, and you have two types. You have the mineralized freeze-dried bone allografts and the demineralized bone matrix. And now we're going to go over both of them. So the FDBA is a mineralized matrix, which composes of bone growth, which supports bone growth and supports the development of new bone tissues. It is processed to remove any potential harmful cells and viruses, reducing the risk of infection or immune reactions, and they can be used in combination. And we're going to go over it later. FDBA are used a lot in combination and also in CAD-CAM technologies, which is computer-aided manufacturing, computer-aided design, which in my opinion is pretty cool. And now we're going to continue to the demineralized bone matrix. So this type of bone graft is, you could say, better for vital bone formation and bone regeneration. It has a lot more of matrix, of collagen, growth factors, other proteins for bone formation, and it simulates the body's natural bone building process. Now, what are their origins? So as you can see here, we have a mandible, and it's actually a cadaver's mandible. And later on, I'll show you a case that this mandible was integrated into a patient. And these are holes here that were used to add mesenchymal cells to promote even further bone regeneration. So allogenic bone grafts can come from alive or deceased patients. Alive are from trauma patients that have been went through trauma, and deceased are donors. So how can a genetically different human be a donor? Well, actually, bone donations are the second most common transplantation tissue, second to blood. It is used extensively in orthopedics, neurosurgery, and craniofacial surgery. Now, this is being possible because of the processing. There has been heavy processing also for freeze-drying technique and for the demineralized freeze-drying technique. Now, we do have some complications with that because it's, again, a different genetically different tissue, transplantation tissue. So you have infections of transmissions from donor to patient. You have foreign body reactions, and you have allergic reactions. And we need to, as clinicians, we need to take care of that, and we need to do some tests for allergy or other sensitivities. So what are the properties and the advantages of allogenic? Well, first of all, allogenic provides more structural support and less bone growth than autografts. But is that so? Because autografts are the same, from the same patient, so theoretically it should be better, but you have some contraindications to that, which allogenic could go over and be better. So one of them is a shorter surgical procedure. It is very, very helpful. You don't need to do general anesthesia on the patient to do a second, a more extensive surgery. You have unlimited quantity. So if you have very, very big trauma, if you have full mandibles, if you have basically pull that you need to have many bone material. You can use it in CAD-CAM technologies. It's easy handled, and you can use local anesthesia, so you don't need to have a hospital setting for it. So what are the indications? I just mentioned it, so I'm just going to go over real quickly. So large and complex bone defects, insufficient autogenous bone, minimal morbidity. You have less morbidity with allogenic compared to autografts because of the things that I mentioned before, and the avoidance of the second surgical. Now, if you remember the mandible before, this is actually the mandible here, that was being transplanted to the patient. So again, the contraindications, if you know any allergies, active infection or systemic diseases, and prior history for immune-medicated patients. So these are some of the recent literature and innovations. I'm going to go over it really quickly. The first one is a customized, basically this is a case study that they did a 5-year follow-up. This was one of its kind for a customized for a customized scaffold for the bone. So this is a 6-month re-entry. You can see really good healing here. This is a histological section, and you can see that it's very well vascularized. You have osteoblastic linings, and basically it has very good indications for proper bone formation, even though it's allogenic and it's transplanted. This is a second. Can I do that? This is a second case. You have CAD/CAM technologies, basically, that you can integrate allogenic bone grafting. So here we can see a CT scan on the left, and on the right. But we can see a CT scan, and basically what they do here in these patients is that they put the CT scan into designing software, and then you design a scaffold. So this is the digital design. You can see it again here in a better view. This is from the digital software. And after that, you can see the patient here with the scaffold right here. You can see the implant. They did very good restoration here. And now I'm going to show you a clinical case from Dr. Kesaris. So this patient came to his clinic with a huge osteoblastoma on the right mandible, which needs to be taken out immediately. So he took it out, and we need to fill in that space. So what he did is that he took a donor. This is the mandible from before, and he took a donor mandible, and these lines are cut lines. You're going to cut the bone here, and for the condyle, he put a rib, costochondral graft, from the patient itself. So this is a combination technique of both autogenous and allogenous. This is post-chondrograft. Now you can see here the combination. So this is the rib, this is the donor mandible. Also, we took some hip graft from the posterior hip for inducing even more bone growth. This is the surgical procedure here. You can see the hip autograft. You can see the scaffold. You can see the rib. And this is the final result. You can see here a breathing tube. The patient will keep his mouth closed for 6 months. He can't open the mouth. But yeah, I think it's really cool. And thank you so much, doctor, for showing us this case. And I would like to thank you all for your attention.
So, in addition to what my colleagues have previously presented, I will be presenting xenografts. So, what are xenografts? It's the transplant of an organ, tissue, or cell to an individual of another species. They have different processing methods, and they can affect its resorption characteristics and its osteoconductivity. The processing method should result in a graft that promotes uneventful healing, osteoconductivity for bone formation, anorganic grafts, and all the remnants of the donor animal must be removed to minimize antigenic responses. So, different manufacturers have their own specific protocols for bone preparation, leading to several methods for processing the xenografts. One of the methods is heat drying process, which involves room temperature between 250 degrees to 600 degrees, or temperatures ranging from 900 to 1200 degrees. The resultant bone is calcium phosphate material with lower crystallinity compared to synthetic calcium phosphate sintered at high temperature under pressure. The final heat treatment is at higher temperature. The calcium phosphate crystals in the xenografts have high crystallinity and hence slow resorption. So as I have previously mentioned, we have several processing methods. This leads to several xenografts, giving us to several procedures, meaning low temperature processed xenografts can be used for restoration of bone after tooth extraction, only with high temperature processed xenografts for rich contour. Either low or high temperature are used for gaps, and all xenografts work in the sinus. As a matter of, as a note, high temperature xenografts have less resorption. So, going back a bit in history, transplantation of animal organs into human has long been an appealing as a possible solution for organ shortage. Why is that so? Because we have less organ donors than people who need those. We have actually less donors and more people who need those transplants. So this goes back to 1667, when a French doctor decided to go to a farm and perform human blood transfusions. His first patient was a 15-year-old boy that miraculously survived. It was a procedure of blood transfusion from a sheep. The boy miraculously survived because he was given a small amount of blood. This is how he withstood the allergic reaction. Further on, this procedure was banned because more patients died. Xenografts can be of bovine, porcine, or equine origin. The bone is cut into small pieces and then dried. Cortical and marrow bone are often separated to provide either cortical or cancellous graft material, and the bone is then degreased, meaning we remove the lipids, proteins, and collagen of the bone. The bone is then washed copiously, and final anorganic process involves heat treatment. Indications: it's before implant placement, restoration bone volume after tooth removal, alveolar bone augmentation, in periodontal disease, alveolar socket preservation, sinus lift, although it's not very common, and vertical height restoration for placement of implants in the posterior region of the maxilla by grafting the inferior aspect of the sinus floor. Contraindications. The contraindications are very similar to the ones of the implant, meaning immunosuppressive patients, patients who are receiving intravenous biphosphonates, alcoholic patients, and smokers. Complications include bovine xenografts being not biodegradable, sinus and maxillary bone pathologies, displacement of the graft materials, implant failures, soft tissue fenestrations, and chronic inflammation. Usually, how they were dealing with the complications, they were removing the xenografts so that we do not have further allergic reactions. So I will be presenting the case of Dr. Casares as well. Here you can see genial blocks that are combined with xenografts, and here we can see the anterior hip graft. So here, one second. You can see from where the hip graft was harvested. We can see extreme maxillary atrophy. And in those images, we can see the cold, solid bone graft, which was then stabilized with screws, as you can see here, and against the maxilla, and we kept them for 6 months. After 6 months, this was the panoramic. We can see the screws. And clinically, we could see the screw as well. Okay. And then we had some gaps in between them. This is why we put in between them xenografts. And on the other image, you can see the implant placement. We put implants and xenograft membrane. We use the synthetic membrane of the mitral valve of the pig. And you can see here the implants and the pins over here. And as a final picture, this is the implant, and those are the pins. Thank you.
Hello, everyone. Today I'll be talking to you about alloplastic grafts. So what are alloplastic grafts? Well, they're synthetic, inorganic, biocompatible bone substitutes that function as defect fillers to repair skeletal defects. They derive from a plethora of materials such as silicone, calcium phosphate, acrylic, hydroxyapatite, and many more. And here we can see on the right is simply a silicone implant, which is used to mimic the mandibular angle. Now, what are the indications? Well, the indications are it's used for developmental abnormalities, functional deformities, destruction of an autogenous bone graft by pre-existent foreign body reactions, and failed tissue grafts. Now, what are the contraindications? Well, in the case of an allergy, in those documented allergies to implant components, which may be present before or after and may manifest after the placement of prosthesis, infection, this risk may be due to the fact that synthetic materials can act as a foreign body, increasing the likelihood of bacterial colonization and infection. Age, there is evidence suggesting that younger patients may have significantly greater resorption rates. Greater metabolic activity in younger patients could lead to quicker resorption. And lastly, uncontrolled systemic disease. What are the advantages and disadvantages? The advantages are it allows for customizable shape and volume, no donor site is needed, and there's shorter operation times. The disadvantages are that it lacks osteogenic properties, portions in your graft may remain in your body for years to come, and it's limited in its ability to heal large defects by itself. Now, a particular article of interest was conducted by Oliver and his fellow colleagues, and they mentioned that there are several factors which influence the selection of alloplastic materials, such as the site, type of surgery, desired aesthetic outcome, and the risk of complication. This review consisted of over 2,100 patients across 23 articles in which the findings were stratified by anatomical distribution, indication, specific material, and the outcome. Now, the results based on the materials used show that merceline resorbable mesh, which is this material on the left, had the highest rate of infection. Methyl methacrylate, which is the material on the right, had the highest rate of hematoma, and Lactazorb in the middle had the highest rate of poor aesthetics. Now, results based on where the implants were placed shows us that malar implants, or what we call cheek implants, had the highest rate of infection. Orbital implants, shown by the first and second skeleton, had the highest rate of inflammation, and nasal implants had the highest rate of poor aesthetics. Now, let's talk infections. Implants have the capability to limit bacterial invasion while also maximizing the host's ability to combat infections that could arise. Infections in studies were often associated with porous materials, such as merceline mesh, which, as mentioned before, had the highest rate of infection. Now, why is that? Well, porosity helps explain why infection occurs. Now, what we can see here are two cells. On the right, we have a bacterial cell that wants to invade and infect the implant. And to enter within the material itself, it requires a pore size of 1 micrometer, as shown by the diagram. The left represents a host macrophage, which requires 50 microns to enter the implant and prevent the infection. Thus, pore sizes between 1 to 50 microns may theoretically impose a more serious burden of infection, and this would allow for invasion of bacterial mediators, but not host immune cells. Now, recombinant DNA fits in its own bracket as an alternative method of filling in defective spaces, and it works as such. A strand of DNA which codes for a gene of interest is isolated from a donor cell. A plasmid, which we can see here, is then acts as a vector and is isolated from the bacterial cell. In order for these two to bind together, a restriction enzyme is used to remove the unwanted bits and ensure the pair to form. DNA ligase functions to pair the two to form what is now known as recombinant DNA. Recombinant DNA is then introduced into the host cell to allow division and expression of the gene, as we can see here. Now, why is recombinant DNA important? Well, in 1965, Marshall Urist, a researcher, conducted an innovative experiment with very promising results. It involved injecting demineralized bone matrix into the muscle of a rabbit's leg, and after 3 weeks he observed the formation of ectopic bone. Thus, it was concluded that the bone matrix contains some important factor capable of performing self-induction. And soon they discovered BMP2, or what is known as bone morphogenic protein, along with other growth factors, was the reason for this bone growth. And I'll explain how it works. When someone breaks their bone, as we can see here, platelets become activated and growth factors are then released into the bone matrix. BMP, through a process known as chemotaxis, sends a signal to the progenitor cells, which causes them to migrate to the site of injury. These cells then differentiate into bone-forming lineage and form new bone as shown. An important note to remember is that with bone, is that the scaffold builds the foundation for the future. The following cases are courtesy of Dr. Keseris, and what we see here in front of us is a gel foam sponge which has been impregnated with BMP2 and is being used and cut in thin strips. The spongy bone graft has been considered an ideal carrier as it acts as a scaffold promoting early vascularization and osteoinduction and provides osteogenic cells. It is biocompatible and has the ability to adapt to bone defects. Now, this is the case of a patient wanting to undergo bone placement. However, as we can see here, the bone height is insufficient due to the maxillary sinus, and it's dropped all the way down due to something called sinus pneumatization, and hence a sinus procedure was indicated. A trapezoidal flap was made, and osteotomy was done to expose the sinus. And here we can see, it's quite hard to see, but this is just where the sinus membrane is. We place in layers the gel foam sponge, which as mentioned before is simply a median to hold the BMP2. A PRP membrane is placed on top of it, and this is the post-op photo from the procedure. And now, if you can see, this area has now become radiopaque, which is indicating the formation and the increased density of bone. And here we have the placement of the implant. Another interesting case was the case of a 47-year-old man who fell 9 meters and had major craniofacial trauma, and this gap, which we can see here, had to be left like this due to a large hematoma. Now, notice the indentation on his forehead. What we are seeing is the absence of bone, and this patient was able to feel his own brain when he applied pressure in this area. And this is simply a superior view showing the indentation. This is a 3D reconstructed CAT scan of the patient, and we can see the frontal bone deficiency and the fracture lines. This is just another view. The CAT scan was then transferred to a 3D printed model. Now, prior knowledge would have indicated an autologous graft, and this would have simply involved harvesting parietal bone, involving just a compact bone layer, and by measuring the gap simply using a pencil, the same part would have been excised, and the needed amount of bone would be placed with screws and plates. But we found out after many years that this caused resorption, and hence it was avoided in this case. And the best case scenario is to have a custom-made alloplastic graft made from titanium, which is assisted by 3D software technology, which would help fabricate the graft
Oops.
We're missing the fun part.
Yes. Okay, perfect. So now we will continue with the second growth factor category we're going to talk about. These are the vascular endothelial growth factors. They promote vascularization, as their name indicates, angiogenesis, and formation of new vessels. They control the bone development during the promotion of vascular structures by acting on osteoblasts. Blood vessel formation doesn't occur at one specific time only. That means that the position of one specific vascular endothelial growth factor at a specific period of time won't lead definitely to new bone formation. So we need to know that also BMP2 has been used with vascular endothelial growth factor, which is a very nice combination that promoted a faster regeneration of bone. The fibroblast growth factors, FGF2 specifically, stimulates the proliferation of periosteal cell, osteoprogenitors, chondrogenitors, and enhanced callus formation. It stimulates proliferating fibroblasts, which are associated with human odontogenesis, repair, and regeneration, proliferation of capillaries and vessels, and differentiation of cellular precursors to osteoblasts. They have generally been associated with improved fracture healing, although some studies have shown ineffectiveness. And it's very important to mention that they have a biphasic effect. That means that in normal concentrations, they produce the desired effect, but in higher concentrations, they produce an inhibitory effect. The TGF-beta, the transforming growth factor beta, it's a secreted protein and it's a part of cytokines. It's a superfamily that includes actins and inhibins. And there are three isoforms most commonly found, the Vita1, Vita2, and Vita3. They control proliferation of most cells in association with immunity, cancer, AIDS, even Parkinson's disease, and diabetes mellitus. The infarction in bone morphogenesis and healing, and are diversified according to the tissue in which they are secreted. Most tissues have an increased coding number of genes for TGF-beta, so that means that many different structures have high affinity for this specific growth factor. Now, we are going to concentrate a little bit more about this one. These are the platelet-rich plasma, and this is an autologous source of TGF-beta that we explained before, that is obtained by sequestrating and by long-density centrifusion of platelets. And as seen in the picture here, after the blood is collected and is obtained, then it's centrifuged with the heart spin centrifusion, as I explained, and then the PRP, which is the platelet-rich protein that we need, is only isolated in the bottom part, so it's a very small amount here that we can actually use. So most of the plasma is platelet-poor plasma. That means that we are not able to use it for the regeneration of bone. So, what PRP does? It increases the platelet concentration when it is placed in grafts. And why do we need that? Because this leads to an acceleration of repair and production of a denser bone. Studies have reported a positive effect in enhancing both soft and hard tissue healing, and others showed no benefit at all in the implant survival rates only. It is usually added in membranes, so it is embodied in them. And on the picture on the right, we can see a cocktail of different growth factors that can be used, for example, in different cases. And now we can observe how blood is collected in the office, chairside, and it's centrifuged with this machine here appropriately. And here we can observe in reality how the plasma is differentiated nicely from the other constituents, and we suspect at the bottom of this plasma to have the platelet-rich plasma that we're going to use. At the final picture, there is an example of a xenograft that was mixed with PRP, so we have an idea how it looks like clinically. But which growth factors have been used generally in bone grafting? The newest trends and technology is following the PRP principles and has led scientists to obtain concentrate, such as concentrated growth factors. They are a valid aid in speeding up the process of bone and soft tissue regeneration, and they tend to speed the osteoinductive activity. That is why they were also used in many cases for wetting the implant surfaces of implants. The CGF can be used alone or together with other biomaterials or autologous bone. But more research is needed regarding this, although there are promising results. And as seen in the picture, we can identify the zone of CGF and then how it is embodied on the membrane here. So another novel technique that I want to show you here is we can observe how autologous bone granules can be collected chairside. So whenever we cut with a round burr on the chin of the patient, we can, instead of taking a block, we can actually use the burr and collect all the granules of bone, both cortical and cancellous part, with a single-use filter, as you see here, that is also connected to the suction tip. And the bone then is collected there. With this bone, we can do, for example, a sinus lift procedure. They are all collected there through this filter here, and it's all packed in here, and at the same time, the blood is expelled through the suction system. So what we achieve at the end is to pack 100% of bone in this specific syringe. Then we can remove it from the suction tip and place it, for example, underneath the sinus membrane. And another schematic example that we could use this is when we have an extraction of an anterior or a posterior tooth or any type of a bony defect. We can pour just the granules in there. And then, of course, we will cover with a membrane embodied with PRP, and then we can suture. So let's discuss a little bit more about the future trends. What is mostly needed is the development of new technologies for precise delivery. We don't need more growth factors. We don't need more molecules. We just need a way that we can give them to the patient correctly. Since we might face side effects from the imprecise use, and specifically for the vascular endothelial growth factor, which should be localized and transported to a specific target tissue for a prolonged and a sustained time, otherwise it will lead to tumorigenesis. So there are some new methods, such as microfluidic approaches, that show promising results, and we can have precise encapsulated growth factors that have regulated release rates. And also, as Zaid, our colleague, said before, the recombinant human growth factors, which leads to the latest biotechnology approaches. And now, before I finish, I would like to share with you some cases courtesy of Dr. Kesaris as well. This is a sinus lift case, and we use an autologous hip graft as a block. And next we can see how we prepare the sinus membrane with a burr. We lift it up as it's seen in the picture here, and then here the hip graft is placed. And although it is not shown in this picture, a screw was also used to stabilize the bone in this specific location. And our last case for today, it's a mandibular atrophy case. And here we can see the corticocancellous anterior hip graft. And these are in blocks, as we can observe. And in the first picture, we can see how we stabilize the graft with the screws, here, if you see them. And the grafts were used and covered again with a PRP membrane. And in the next picture, we can see the implant placement, which took place, of course, after the remodeling phase, so 6 months after. Here you see the implants. So we achieved to have more bone. This is what we needed from the beginning in a case of atrophy. Have more bone so we can place the implants and provide the patient what he needs. And lastly, this is the clinical picture of the case showed previously. And except for the x-rays, we need to have a clinical idea and to correlate. So that was my presentation as well for today. To conclude, from all of us, we would like to say special thank you to Dr. Kesaris, both for assisting us making all this journey in maxillofacial bone grafting and for sharing his cases with us. These are some current evidence, and some of these were used also for the construction of this presentation. And from all of our team, thank you for your attention.
As I said, we hope you all enjoy it as much as we did, and we're open to any questions. Okay, then. Yes, doctor.
Thank you so much for the nice presentation. I'd like to ask a question to Dr. Pisares. So when you decide to select as an oral surgeon what kind of intervention you are going to do, are you looking to like some factors to decide whether you are going to take bones from different parts of the body and then just replace the missing part? Is it depending on the size of the lesion? Is it the location of the lesion? Or
Thanks for the question. It's all those things that you mentioned, and what really matters is, out of my own experience, what works better in each surgeon's hands. So, in my hands, you might see autografts work better. In some other surgeons' hands, you might see allografts, xenografts, or alloplastics work better. What I can say for myself is, as I said previously, initially in the times of dinosaurs where I was trained, we used to do a lot of aggressive harvesting, cranial grafts, hip grafts. Nowadays, after 31 years of practice, I am less and less aggressive. I should say I have become more and more conservative, although I'm a surgeon. And I like to use less invasive techniques since we have so many different and well-working and proved that they work well alloplastic grafts. Those, along with growth factors, I think they can be a really nice combination for minimally invasive reconstructive techniques. Yes, we're actually get married to these patients, and initially we follow them for every 6 months for the first year, then every year on an annual basis for the first 5 years, and then every 3 to 5 years for the next 10, 20 years. Now, it is really important as doctors to understand that we learn, and what matters is the follow-up. I mean, I haven't met anyone who says I'm the perfect surgeon, and I haven't met anyone who says, as a surgeon, I have no complications whatsoever. So we used to say, our professors in the States used to say, if you hear anybody saying this, either he doesn't operate or he's lying. So there's no way. That's why within the last 10 years of my practice, I tend to present mostly my complications. Why? Because I'd like to share this with my colleagues and have them give me their own opinions out of their own experience and see what works better for them. So going through that, you just try to measure the morbidity and mortality of those cases, the failure rates, actually the resorption percentage after so many years, 5, 10, 15 years. The truth is that I have seen through the past 30 years about 20 to 30% of resorption among all these kind of grafts. So we all expect some resorption. This is why sometimes we do some overcorrection. Now, I have seen in some cases without any reason, and I guess this would be idiosyncratic, and you will find this in the literature, up to 80% resorption. Thank God this is less than 0.5%, but we do see it. And then the patient might become angry and say, why did we do all this? What happened? Where did the graft go? What did you do wrong? So another issue here that comes up for all of our colleagues and students is we really have to explain before doing the simplest operation to all of our candidate patients possible risks and complications and make sure they understand them. Sometimes I see in our clinic that we're all in a rush and we say to the patient, okay, why don't you sign so we can start? Yeah, well, the patient for sure will sign, but did we ever explain what they might expect, what they might see? And then if we haven't explained to them, even for the simple extraction, like, oh, you're going to have some swelling, you're going to have a little pain, or you might have a lot of pain if you smoke, or if you don't smoke, they call back and they call all the time, our students, and their students are worried. Oh, what did we do wrong, doctor, or what have we missed? So we didn't miss anything. We didn't do anything wrong. These things are expected. So what really makes us good doctors, if you want my opinion as a surgeon, is taking care of our complications. Otherwise, it would be like, okay, what did you do? I will do the same thing. We will become monkeys. So knowledge is making a good doctor, along with compassion and taking care our patients post-operatively, long-term. Always follow up, follow up, follow up. It's really important. And document. I mean, I know it takes time to learn how to write as a medical doctor, patient progressing well, wounds are healing well, or dehiscence, infection, the wound had to be irrigated, and we will follow up again, and antibiotics given in which frequency and how many days. So these are really important because this is how we learn. It is not just operating. I mean, operating might be the center or the beginning of the whole idea, but what really matters is after that, following. And if you want my opinion, criticizing, self-criticizing. We're doctors and our patients depend on our knowledge and experience. So it is not bad to say, well, what did I miss this time? What am I missing? That's why we learn protocols, we learn biology, biochemistry, all of these basic sciences. These are the ones which explain what might have been wrong. And this is what makes us knowledgeable and makes us able to explain to the patients in a simple way what really went wrong or what might go wrong from now and then. So all these things, that's what you're here for, to learn all these things. And if you want also another opinion of mine, we as supervisors learn from you, the students, as well. So this is a two-way procedure. We learn from each other. That's why we should all be open. Never say never mind. Oh, I don't need this. I don't need to learn that. You know, my son is here, who is a first-year medical student. Now, yesterday they finished the last midterm exam, you know, embryology, histology. Oh, why do we have to learn all this? I mean, why? I mean, anatomy is important. Physiology is important. Why do we have to learn all this? I said, this is why you become a doctor. You need to learn all this. So what am I going to remember after all this? You will remember whatever you need to remember. And then again, we as doctors tend to forget a lot. And this is why a nice motto that I have never forgotten since I was a resident in the States was, every day I will read a little more than yesterday. So this is what makes us scientists. It is not a procedure that we put aside and we forget. Reading is really important. Reading basic sciences. Biology should be the first one, if you want my opinion. We know the wound healing process through biology. Plastic surgeons, you know what makes a best plastic surgeon? The one who places the best deep suturing layers. And this is why we don't get scar tissue formation, connective tissue, because we don't have any gaps. And they all say, wow, this guy is a magician. Well, this guy knows very well what he's doing because he knows very well the basics of biology, healing process. Okay? Thank you.
I have a question regarding the case of combination of autogenous and allogenous graft. It was a mandible, I think you cut one part of the mandible. I was surprised that you cut the part of the condyle and you replaced it with the hip part of the bone, right?
Okay, perhaps it was not explained as well. It was a hemimandibulectomy because we had an extensive and recurrent ameloblastoma. So this was non-controlled anymore. That's why we took the whole part of the mandible along with the condyle. And one way to really reconstruct this, just one way, not the only way, was to place a rib graft as a condylar process, just because we find some tissue, chondral tissue, that can function within the temporal fossa, okay? Sometimes, I have done several cases as well with sternoclavicular grafts, which histologically are exactly identical with the temporomandibular joint. But it takes longer. I mean, costochondral graft takes about 30, 40 minutes. Sternoclavicular graft takes about 3-4 hours to take it. So it really depends on the idiosyncrasy of the patient and how long your procedure want you to be, and the age of the patient. All these things that Dr. Salim mentioned. Another way would be to put just a titanium plate with a condylar process, and a lot of my colleagues do this, and it functions pretty well. Or, in case we have left some of the mandibular ramus, we can use a total joint prosthesis like the orthopedics use, and this can work as well fine long term. So we just try to pick something that works better into our hands. If you want my opinion today, I would use a total joint prosthesis, if that answers your question. No more questions? Okay, I hope most of the stuff was understandable to you. It was too bad that our presentation was not showing all this work my team did. These were 3D modeling pictures that were moving and showing the recombinant DNA, the experiment with the rabbits, but unfortunately this was not seeable over this presentation. Something perhaps went wrong through technology, but I reassure you that my students here did an excellent work. They really overwhelmed me, and I can't wait for the next year to see the next team working with such a great warmth and willingness. Thank you for being here. Thank you. Okay, next.
How may I be of service? What?
you're good. Do your thing.
You go.
Should we start? Maybe, yeah.
Okay, I think we can start.
Yeah? Should we close the door?
Yeah. The door, the door. The door.
So, good evening, everybody. I'm Avram Cassuto. This is my colleague Evita Vrisa, and we're here to welcome you to the first free paper session of this evening. The session is going to be chaired by Dr. Konstantinos Zamboglu and Dr. Vasiliki Danilatou.
And we're very honored to have here with us Konstantinos Zamboglu, the Vice Director of the German Oncology Center and the Assistant Professor of the Freiburg University, and Vasiliki Danilatou, our Professor of Hematology.
Yeah, dear chairs, thank you very much for the kind introduction, and congratulations for the organizing committee. I know how hard it is to organize such an event, so heads up for doing this. Today we have four really interesting presentations coming from different fields in oncology, and we are happy to invite the first speaker, impressive from the first year of the European University, Aphrodite Persephone Pascoe, and she will talk about the use of methionine as PET CT tumor imaging agent.
Nope.
Good. Which one is it?
This one. And I move it with these ones? Yeah. Okay. That's me. Okay. There. Is everything okay? Are we ready to start? Okay. Good afternoon, everyone, colleagues, professors. It's an honor to be standing here as a first-year medical student, being able to present my research. This presentation is actually based on an assignment my colleague and I, Alexandros Kordadakis, worked on for physics and biomedical sciences last semester. I thoroughly enjoyed this course, and I wish my final exam score could have reflected how much I enjoyed it, but anyways. The topic of our presentation is the use of 11-C-methionine as a PET CT tumor imaging agent. I'm going to be talking about the specific radiopharmaceutical 11-C-methionine and how its use could be more beneficial in comparison to other tumor imaging agents used in nuclear medicine. This is a brief outline of the presentation. So, what is nuclear medicine? Yes, okay, you have to know anatomy, radiographic positioning, physics, and how to properly apply the inverse square law to kilovolt peak in millimeters per second. But all that's just complicated and a little bit boring. It's actually just a specialized area of radiology that uses small amounts of radioactive substances, also known as radiopharmaceuticals, for diagnostic and therapeutic purposes. The applications of nuclear medicine are based on the type of radiation used. In most diagnostic procedures, the radiopharmaceutical consists of a biologically active molecule and a radioisotope tracer, which are injected into the body intravenously. Then, different types of radiation detectors are used, which detect the radiation emitted by that specific radiopharmaceutical. Generally, gamma cameras are used in diagnostics, in which technetium-99m radiopharmaceutical is the most widely used, while for therapeutics, beta radiation emitters are used instead, in which iodine-131 is the most common radiopharmaceutical. Overall, nuclear medicine helps diagnose and treat abnormalities in the early stages of various diseases, especially in cancer. It's a vital tool that all doctors rely on. In a way, it becomes a doctor's eyes when they can't see inside the body. Moving on, let's talk a bit about the various imaging modalities used in nuclear medicine.
Techniques used for molecular imaging include positron emission tomography, or PET scan, single photon emission computerized tomography, SPECT, magnetic resonant imaging, or MRI, ultrasound, and many more. The scans created by these specific techniques create images based on the function of an organ, tissue, or bone, as opposed to other imaging techniques such as an X-ray, which focuses only on the structural appearance. So let's talk a little about the most common radiopharmaceuticals used in SPECT and PET scans. Technetium-99m is the most common radioactive isotope tracer used for SPECT nuclear imaging, as it is used to detect and diagnose a wide range of conditions. It's also really popular due to its minimal risk of toxicity with low gamma ray emission and a half-life of 6 hours. F18FDG, on the other hand, is the most common used in PET imaging to detect metabolic activity in the body. It is used in various diagnostic applications, including oncology, cardiology, and neurology. Again, it's favored due to its low radiation emission and a half-life of only 110 minutes. Okay, let's get into the main topic of this presentation, which is 11-C-methionine. 11-C-methionine is an essential amino acid which can also be used as a radiopharmaceutical in PET scans. It's especially useful in neuro-oncology due to its high sensitivity in identifying brain tumors. It's important to note its use as a radiopharmaceutical in the hybrid imaging technique, PET CT, due to the fact it allows tracking of selected metabolic pathways and cell functions in a precise fashion. More specifically, it is transported across the blood-brain barrier and is preferentially taken up by tumor cells because of their increased demand for amino acids. Due to its extremely short half-life of only 20 minutes, 11-C-methionine enables patients to be exposed to lower levels of ionizing radiation than other radioisotopes, rendering it a valuable tool in various fields such as neuro-oncology, hematology, and endocrinology for the accurate monitoring of metabolic pathways and cell functions. I'm going to talk a little more in depth about the application of 11-C-methionine in the field of neuro-oncology. The largest application of PET CT using 11-C-methionine is the diagnosis of brain tumors. It is a relatively new technique, mainly used to evaluate primary central nervous system tumors, specifically gliomas, which are the most prevalent malignant primary tumors of the brain. Moreover, the tracer demonstrates a low uptake in healthy brain tissue and a favorable tumor-to-background ratio, as well as assisting in determining the site of brain biopsy, planning radiotherapy, and monitoring treatment progress. Finally, the intensity of 11-C-methionine uptake in a tumor is associated with its grading and malignancy. In tumors with high proliferative potential and high histological malignancy, higher tracer accumulation is often seen. This reason makes 11-C-methionine often used in diagnosis of the effectiveness of surgical treatment, as well as to see whether or not recurrence after chemotherapy or radiation therapy is likely to happen. Moving on to hematology. Multiple myeloma is the second most common hematological malignancy and remains incurable to this day despite therapeutic advances. In vivo and in vitro experiments proved 11-C-methionine having a higher sensitivity than other tracers in the detection of lesions in multiple myeloma. The likely advantage of 11-C-methionine over other tracers used is associated with the incorporation of it into the immunoglobulins synthesized in the actual lesions that multiple myeloma creates. Today, a large study consisting of 650 participants is ongoing, aiming to assess 11-C-methionine in newly diagnosed nervous system lymphomas and sarcomas with a planned ending this year. Lastly, we're going to be talking about the use of 11-C-methionine in endocrinology, which I personally find the most intriguing. Hyperparathyroidism, a relatively common condition affecting the thyroid. The main method of treating it is the surgical removal of the autonomic parathyroid gland. It is important to note, however, that this surgery is difficult due to the fact that precise preoperative localization of the autonomic parathyroid gland is necessary before it starts. Methionine is actually a substrate in the production of the parathyroid hormone precursor and is thus already actively accumulated in parathyroid gland cells. Research has actually shown evidence of the superiority of PET CT diagnostics with 11-C-methionine in patients who have recurrent hyperparathyroidism. I'd also like to touch on the safety of these clinical studies The absorbed dose that the patient receives from the isotope during the PET CT with 11-C-methionine is more than 4 times lower than the dose absorbed during standard scintigraphy. Despite its usefulness in detecting cancerous tissue and monitoring tumor progression, 11-C-methionine PET CT imaging has several limitations. Firstly, false positives can occur due to inflammation, infection, tissue repair, and specific conditions like sarcoidosis and multiple sclerosis. This may lead to the misinterpretation of results. Secondly, accessibility is limited due to high production costs and the need for specialized labs. This may restrict its availability in certain regions around the world. Thirdly, detection challenges arise when dealing with early-stage cancers or those with low metabolic activity, making it less effective for all tumor types. Fourthly, interpreting 11-C-methionine PET CT images can be difficult due to factors like low uptake, complex anatomical regions, and variations in methionine metabolism caused by other metabolic conditions. Medical conditions, excuse me. Lastly, we need to consider radiation exposure. While the exposure is relatively low, it's important to weigh the risks and benefits, particularly for patients requiring multiple scans. Despite these limitations, 11-C-methionine remains a promising future tool in cancer detection, monitoring, and treatment guidance, ultimately leading to improved patient outcomes. In conclusion, 11-C-methionine PET CT imaging is a valuable diagnostic tool for various diseases, offering high sensitivity, low half-life, and precise metabolic information. Challenges include limited availability, the need for larger studies, and false positives. Despite these limitations, 11-C-methionine holds promise for guiding treatment decisions and improving patient outcomes. Ladies and gentlemen, thank you very much for your attentions. And I'm available for any questions either now or if we have time. Yes, of course.
Thank you very much for this excellent talk. To be honest, I'm really impressed.
Thank you so much.
Very well structured, and your style, how you presented this data was extraordinary. So congratulations for this.
Thank you so much.
And yeah, we have time for 2 questions. I think there was.
Hello. Thank you. Excellent question. I did touch on this a little bit in one of the slides. Obviously, there's going to be risks with any radiopharmaceutical used. It's unfortunate, but it is what it is. 11-C-methionine isn't different. The difference is that it's a very low half-life of only 20 minutes, so the exposure to radiation is so much lower than so many other radiopharmaceuticals used. But that's also a limitation, so you gain some, you lose some.
Is there another question from the audience? If not, I have one question. You know, in nuclear medicine, there is an evolving paradigm of the so-called theranostics. And what does this mean? You have a target, for example, iodine or PSMA for prostate, and you can couple the tracer either with the diagnostic or with the therapeutic emitter. And my question is, do you know any data for methionine, whether there's also a therapeutic approach using this theranostics?
Yeah, so I did mention that gamma cameras are mostly used for diagnostics and beta radiation is used for therapeutics. 11-C-methionine right now, because it's still in the early stages and it's not even an approved radiopharmaceutical, there's no way for it to be used in therapeutics. It's mostly used for imaging and seeing and diagnosing rather than actually helping the patient and maybe curing this disease. It's still extremely early, but the massive research that's happening right now and is probably going to end by the end of this year with 650 participants is looking really promising in hopefully helping patients with all of the conditions that I described in today's presentation with the use of 11-C-methionine.
Nice. Thank you very, very much again.
Thank you.
And now we are happy to explore a new topic in cancer. Stavroula Bernica is going to have a talk about natural biomolecules and derivatives as anti-cancer immunomodulatory agents. Dear Stavroula.
Hello, everyone. Most of you know me. My name is Stavroula. I would like to start by saying this presentation has some funny parts because I made it for the students more than the professors, and it's a presentation of the paper as well as a small introduction to some things about cancer and immune modulation. So my name is Stavroula Bernica, and can the CAMeSM person come and is it working? No. I'm going to call the... it worked, okay. So, my name is Stavroula Bernica, and together with Rotem Dayan, Dr. Stefano Tsvetanova, and Dr. Patrikios, we published this paper called Natural Biomolecule Derivatives as Anti-Cancer Immunomodulatory Agents. Now, the what? What did I just say? I said we took some natural stuff occurring in nature that have some kind of anti-cancer effect, and we focused on the effects that modulate the immune system in convenient ways. The ones we studied are artemisinin, anonosins, berberin, curcumin, and EGCG, and also triptolide. Now, some of these worked, and some of these absolutely did not. Why did we look into this? Because natural biomolecules have created many chemotherapeutics, like irinotecan, vincristine, etoposide, and paclitaxel, and there is great interest in researching them for more than one reason. And so this research provides an avenue to improve areas in which current treatment is lacking, like responsiveness, resistance, cost, side effects, and so on. Additionally, new drugs like immunomodulators are some of the most promising current add-ons to treatment. And how did we look into this? We focused on clinical trials, but we also included in vitro and in vivo evidence. We focused on toxicity, side effects, bioavailability, and most importantly, assay interference, which means that some molecule may have an effect which isn't real, which confuses the machines. And so it's a false effect. We split the effects into anti-cancer, treatment aids, and immunomodulatory. So, before I tell you what immunomodulation is, which is half of the paper, I will tell you a short story about what happens normally and what goes wrong in cancer and the immune system. So, once upon a time in a galaxy nearby, there was a cancer cell. And this cancer cell, for some reason, died. And as it died, it released antigens, which are its molecular passport. And so the scouts of the immune system, the dendritic cells, picked up that passport and took it to the lymph nodes. In the lymph nodes, the T cells, which are the scouts and the hunters, they recognized this, and they went out looking for the rest of the cells. And once they found them, they bound and killed them. And so this is the cancer immunity cycle. It's what's supposed to happen, and it's what goes wrong. But why does it go wrong? Because the cancer can improvise, it can adapt, it can overcome this by molecular forgery in many other ways. Hi, this is for the students. Hi, I'm not a cancer cell. Can you help me? And the immune cell asks for some kind of ID, some kind of molecule that will prove what it is. And the cancer cell says, sure, here's my MHC and my PD-L1. And the PD-L1 is like a diplomatic passport. And what this diplomatic passport does is it says to the T cells, to the immune cells, please don't attack me. So PD-L1 is something that says don't attack me, okay? But that's not enough. As I said, manipulation is involved. And so the cancer cells ask for a tour and some snacks and everything with the diplomatic passport. And what this means is that cancer, through various molecular signals, can change the immune system into gaining more blood vessels, more nutrients, and proliferating, metastasizing, evading the immune system, and also gaining resistance. And the cells that are usually, let's say, full fooled into doing this are the tumor-associated macrophages, the myeloid-derived suppressor cells, the B cells, and the regulatory T cells. While some cells that still kind of try and fight it are the cytotoxic T cells, the NK cells, and the dendritic cells. So these still try to do the antigen presentation and the recognition and the attack of cancer. And so, by this point, I've said that there's something that goes wrong, there's this diplomatic passport, and if we took it away, maybe we'd have an excellent target for cancer therapy. And we do. This is where immune checkpoint inhibitors, PD-L1 inhibitors, come in. And so you can see these little antibodies go on the PD receptors, and so the immune cells can recognize the cancer cell and attack it. And these can be given with chemotherapy, and they're very good add-ons to treatment. So we found that PD-L inhibition can also be done by berberine, EGCG, triptolide, and curcumin, which reverses cancer tumor escape and cancer cell cytolysis. But there's more than one target that we identified, because if you go a little bit back, there is this thing called STAT3. And STAT3 regulates transcription of many things, which I don't have time to go into. But essentially, in some cancers, it's upregulated, and it increases survival, proliferation, immune suppression, angiogenesis, migration, and evasion. And we saw that artemisinin, berberine, curcumin, EGCG, and triptolide can stop that, can inhibit it. These molecules also had effects on individual cell populations. And the most important thing is whether they actually worked clinically, if they were tested clinically. Artemisinins did work, but the trials were few. The toxicity was acceptable, and it was mostly promising for HPV-related cancers. Curcumin had many trials, extremely questionable at best, and we tried to explain why this happened, why it didn't work, so on and so forth. Berberine had no cancer trials, just adenoma trials, and it was promising for some things, but in my opinion, not as chemotherapeutic. And finally, EGCG was promising mostly for radioprotection, and it had some trials to it. Another summary. I'm just kidding. Thank you for your attention, and I hope that you learned something. And these are our references. Thank you.
Thank you very much. So we have a second excellent presentation. I must say this was really educating and really nicely presented again. So both of the speakers, congratulations.
Do you have any questions? Yes.
Speaking about the PD-L1,
yeah.
Is it only present on cancer cells or is it also on normal healthy cells?
So basically, the reason why I said molecular forgery, right, is because PD-L1, and correct me if I'm wrong, but it does exist on regular cells, and it is a regulator of autoimmunity. So it prevents regular cells from being attacked by accident. And so basically, it can occur, you know, in cancer, and when something occurs, it's kind of selected for, it stays there, so on and so forth. So it is a thing that exists also in healthy cells. Yeah.
I have one question. You mentioned some drugs you examined. How did you find them? Why you selected these particular drugs? There are so many natural products.
Yeah. So basically, from all of these drugs, right, we selected some representatives that are really pushed for. For example, like curcumin, it was so pushed for, there's still so many publications coming out, primarily literature. And we asked the question, why? Like, why does this have all the activity? What we found out was assay interference, and a lot of them had assay interference. So we tried to identify the most commonly examined molecules, why they're so promising, why they fail in clinical trials, and also examine some that are promising through in vivo evidence and have some few clinical trials. And we kicked out a lot of molecules that were even worse, that were even more disproven, because otherwise it would be a complete paper about disproving. So I tried to keep a mix of both promising and why this should be avoided. Yeah.
Nice. So thank you very much.
Thank you.
Okay. And now we have another very interesting talk about IVF and the associated risk of breast cancer. True or myth? A fifth-year medical student, Iosifidou Christina, is going to present us. Where is Christina?
She's in the other one because she has another one, so we can go to the next
We skip next.
Yeah, until she comes because she's
Okay.
another
Okay, so analyzing the influence of social media in plastic surgery from another fifth-year medical student, Lorenzo De Fraia.
Hi, everybody. Can we exit the previous one, maybe? Yeah. Yeah, but to exit this one.
You already have your presentation here.
We do?
Yeah.
Oh, awesome. All right.
No slideshow.
All right. Thank you. Good afternoon, everyone. My name is Lorenzo De Fraia. I'm a fifth-year medical student, and before starting, I would like to thank the organizing committee of CAMeSM, the professors and the faculty of the European University Cyprus that made this possible. And I would like to thank you for being here today. So today I will present to you my paper called Analyzing the Influence of Social Media in Plastic Surgery. So today we will have a small talk about plastic surgery in general, a brief mention about social media. We will analyze from a study the influence that social media had on the participant on the decision to undergo any kind of plastic surgery procedure. And at the end, we will have some final consideration and additional comments. All right. So what is plastic surgery? From the ancient Greek, plastiki techne, that meant the art of modeling or shaping. Plastic surgery is the surgical field that aimed to modify the appearance of the human body, modify how it looks like for several purposes. Plastic surgery was born actually many centuries ago, as we have some findings from, for example, from ancient Egypt, dated approximately 1,600 before Christ. There are other findings in India on the 6th century before Christ that were later translated into Arabic that had a lot of impact on the Renaissance era medicine in Italy and Spain. And also we have some findings from the Romans that took inspiration from the Greek ancestors to make their knowledge about anatomy. But it's not until the 1800s that with the new scientific discoveries that plastic surgery didn't have, let's say, a major impact. As we can see, in 1800 we have the first cleft palate repair or the first rhinoplasty. But the modern plastic surgery that we know, as we know it today, was because of Sir Harold Gillis, which is considered the father of modern plastic surgery. During World War I, since the development of new weapons and new weapons that let the soldiers disfigurated their face especially, gave the opportunity to Sir Harold Gillis to perform thousands of skin grafts, as you can see in the picture of an injured soldier who received the skin graft in his face. On the right you can see right after getting it, and on the left after healing. I mention again that this picture dates more than 100 years ago. And after that, plastic surgery evolved to what as we know it today. So today, commonly, plastic surgery is classified into reconstructive surgery, aimed to the correction of burn surgery, also craniofacial surgery for the treatment of congenital abnormalities of the face and the skull, hand surgery to malformation of the hand or the wrist, and also microsurgery. And obviously, another field of plastic surgery, probably the most popular nowadays, is aesthetic or cosmetic surgery. Today in this paper we'll mostly talk about aesthetic surgery. So aesthetic, from the Greek word aesthetikos, it means for the perception of senses, translated basically to the passion for the beautiful, is the plastic surgery aimed to modify the body parts of the human body and gave it a better outcome, to make it look better. That's what it's used for. I would like also to mention that aesthetic medicine is divided into, the procedures, are divided into invasive procedures and non-invasive procedures. The most common non-invasive procedures are, for example, filler injection, Botox injection, or laser treatment, chemical peeling, to state a few, but there are dozens of them, as there are dozens of invasive plastic surgery procedures. From the data we have, we know that the most popular are number 1, rhinoplasty, followed by eyelid surgery, followed by facelift, etc. But as I said, also for invasive plastic surgery procedures, there are many of them, and with the new development of new technology and discoveries, many more will come, most likely. I would like also to mention some statistics about plastic surgery. So plastic surgery is one of the medical fields which in the past years has evolved the most. As we can think that in only 1997, so 26 years ago, there were performed 1.4 million procedures yearly. And as in 2020, the number of procedures performed were approximately 5.5 million. This growing in plastic surgery is not also in the number of procedures, as it is also in the economy behind it. So the global market size of plastic surgery, if you think that now it's approximately $69.9 billion, and it's expected to be approximately 140 by 2030. Some people say it's going to be more. Who knows? And plastic surgery is raising popularity also in male patients, but as a source, as statistics taken from the American Society of Plastic Surgeons, they revealed that the vast majority of plastic surgery patients are women. As we see that it's approximately 92% female women and 8% the remaining one to men. All right. I will talk very briefly. I don't need to spend too much time talking about social media or what social media is. So social media platforms are interactive platforms that are used for the exchange of information, content, any form of expression or ideas. What are social media platforms used for? Well, they're pretty much used for any kind of reason right now. Basically, you can exchange conversations via text, call, video call. You can share content like images, video, audio. You can do business. Actually, it's really important, and they're growing pretty fast in the last years, the business social networks. And most likely, and also, last but not least, you can promote people or ideas or products. The most popular platforms as per 2023 are, we all know these ones: Facebook, YouTube, Instagram, Twitter, to name a few. There are dozens of them with many, many followers. As per 2023, the global statistics reveal that almost 60% of the world population, which is approximately 4.9 billion people, have at least one social media account and is supposed to grow in the future. Social media are platforms used mainly, more hours mainly by younger people. As we see in this study, the amount of hours between people aged between 16 and 24 was approximately 4 hours, 49 minutes online, compared to the people aged above 55 years that spent a mere 3 hours online, which means the younger the audience, the more time usually spent online. All right, now we'll actually proceed to the main part, to the juicy part of this presentation. We will analyze the influence of social media in plastic surgery. So from a study, from an interview study found online, which included 816 people aged in the early 20s or late teens, were asked several questions regarding whether they felt like social media had somehow influenced their decisions to consider undergoing any kind of aesthetic procedures. They were also asked other questions like the amount of time online and also what kind of accounts they followed, in particular if they followed accounts belong to influencers and plastic surgeons. So this is what we found on the results of the study we found. And approximately 48% of people revealed, they stated that they felt that social media had somehow influenced their decision to undergo an aesthetic procedure. In detail, approximately 71% said that they would have considered undergoing a non-surgical procedure. 19% were considering a surgical procedure, while 10% would have considered both kind of procedures. Regarding the other questions, the next 4 graphs we'll see, think that the blue participant, the blue columns are the ones that said that they felt like social media did influence their decision, while the gray part are the participant that said that that social media did not influence their decision about considering it. We can note from this graph that patients that previously underwent any kind of procedure were most likely willing to do it again in the future, and those were the ones that mostly said they were influenced by social media about their decision to undergo any kind of procedure. In this graph, we can see that I'm not going to go through all the numbers, but what basically this graph means is that the more amount of time the participant used to spend on social media, the more they were prone to consider themselves positively influenced by social media about plastic surgery. Regarding the questions of the account's follower, I would like to focus main on the people that felt influenced, that there is a big difference between people that followed fashion influencers and people that did not follow fashion influencers on their decision to consider a plastic surgery procedure. As you see that 55% of the people that follow revealed that they were somehow influenced, while only 31% said that they did not feel like, they did feel like social media influence, but they did not follow an influencer. But it's more notable if you follow a plastic surgeon on social media. As you can see, the comparison of the 2 columns here is 66% of people that said that they were influenced, they did follow at least an account belonged to a plastic surgeon or related to plastic surgery, compared to only 32% of the people that said that social media had a positive influence impact. So, what does all these graphs mean? To conclude our findings, we have to say that from this study, we noted that social media did have an impact on the participant, on the account users and the followers. Also, the more time was spent online, the more positive the idea to consider a procedure was likely to happen. And last but not least, following accounts related to plastic surgery or that belong to influencers exporting these kind of products or this kind of content, they do increase the impact and the influence to decide undergoing a procedure in the future. I would like to terminate my presentation to adding some final considerations. So, influence is described as the capacity to have an effect on the character, development, or behavior of someone or something. But it's not necessarily a negative thing, as some people might think. As we've seen since several studies, it has been noted that plastic surgery had been shown to improve or boost the patient's self-image, and also to fight some disorders like social anxiety or depression, or also achieve healthier lifestyle, for example, after
Can you
a
conclude,
liposuction.
please? Can
Yes,
you conclude?
it's the last slide. As I said, to achieve a healthier lifestyle, for example, the introduction of healthier diets and lifestyle and exercises to patients after liposuction, or they can relieve the pain. For example, high surgery can relieve any other kind of face-related pains, as Botox can do it. So I would like to thank you all, and this topic I would like to, we don't have too much information, so what I will propose you is to fill the Google form so we can have a further understanding. In this Google form you will be asked 5 or 6 questions answered anonymously, and you will take 1 minute to complete, but having data about this kind of topic that is increasing a lot in the present and it will increase in the future, it will be useful. Thank you for attention.
Thank you. I'm not sure if we have enough time for questions. Is there any question from the audience? Okay, I guess we need to go to the next speaker because we are out of time.
Thank you.
Apologize for this.
Professor, we actually have 10 minutes.
The next speaker is not here? Ah, okay. Okay, if we... No, we don't. Yeah.
We switch speakers.
We switch.
Yeah. Thank you.
So now we are going to hear Iosifidou Christina, a very interesting topic, IVF and the associated risk of breast cancer, true or myth. Let's see.
Έτσι θα το βλέπουμε. Για να βλέπεις το... ωραία, ωραία. Δεν ξέρω τι γίνεται. Πρέπει να κάνω σλάιτσο. Τι μου πες. Ποιο. Εδώ. Μήπως εδώ, σλάιτσο. Εγώ πρέπει να βλέπω το νότ σου. Ξέρω. Μα θέλω, ναι, τι είναι. Ρίκα αυτό έχει κολλή. Έτσι μου είπαν ότι το κάνεις πάντως. Πατάς εξεκλικ και πατάς το calculation. Present interview. Και το έκανα αλλά δεν βγαίνει. Αυτό τι είπατε εκεί. Αυτό μας το βγάζει ο κύριος στο λαλίπο. Καλά έχει πάει αυτό. Yeah, he's not here. Ask him to come. We're sorry. We cannot.
The IT manager is not here.
Some
so
IT difficulties. We want to have the slideshow.
Yeah, we put this
and
already.
Was it okay for you?
Yeah, sure.
Congrats. No. How do you print?
Είναι αυτόματα.
Okay. But can I ask you?
Okay. So hello, today I will be talking to you about IVF and the associated risk of breast cancer, if this is a true statement or a myth. And before moving on, I would like to start with some epidemiological features. When researching about this presentation, I found out that by 2020, breast cancer became the world's most prevalent cancer type. And when I was being taught about breast cancer, and this is approximately 2 to 3 years ago, maximum, we knew that lung cancer was the first cancer, and breast cancer was just first in the female population. So surpassing lung cancer, I believe, is something difficult and also worth mentioning. And of course, many reasons must be attributed for this statistical change, including, and most importantly, I believe, the screening methods that have now been implemented for breast cancer, but also the Western lifestyle that includes many risk factors. But whatever the reasons, one thing is certain, that breast cancer is a global burden, being the 5th cause of cancer-related deaths in general, and first in the female population. However, there is a silver lining. Breast cancer has also the most survivors than any other cancer type. So we can understand that if diagnosed early and treated properly, breast cancer can be somewhat curable. There are many known risk factors, non-modifiable ones and modifiable, but I would like to draw your attention to some of those. Early age at menarche, greater density of breast tissue, as you can see in the photo as well. It is difficult for physicians to locate and identify a tumor screen-wise through the imaging. And then from the modifiable ones, the hormonal replacement therapy, which I will be analyzing in a bit. And there is also one protective factor that is important to be noted as well, and this is early menopause. Early menopause has been shown to be beneficial in this case, and late menopause has also been shown to be a risk factor as well. So what do all these have in common? All of these lead to an increase to the cells being exposed for a longer duration to the hormone estrogen. And we said about breast tissue and that greater density is a problem diagnostic-wise. However, there have also been associations between greater density of breast tissue and higher levels of estrogen. So about hormonal replacement therapy, it is supplementing the pharmaceutical treatment to supplement for the hormones lost during the transitioning phase of menopause. And it is prescribed by physicians because in order to relieve women from the symptoms that can include anything from hot flashes to mood changes, to night chills, to appetite changes, anything. And all these signs and symptoms are caused because of a loss of the hormones estrogen and progesterone, and that is why the hormonal replacement therapy includes either a monotherapy of estrogen or a combination therapy of both estrogen and progesterone. However, in 2002, a connection was made by the Women's Health Initiative that proved that HRT does indeed increase the risk of breast cancer. And this led physicians to immediately decrease the number of HRT prescribing in the United States. And this has been thought to lead to a 7%, to have led actually, to a 7% drop in breast cancer incidence from 2002 to 2003 alone. So some scientists, of course, made some physicians wonder what is the effect of assisted reproductive technology, ART, to breast cancer. The most common ART method is, of course, IVF, and it is usually implemented secondary to infertility reasons. And reports mention that almost 15% of reproductive aged couples are affected by infertility. And that is why we have over 2.5 million cycles of IVF performed every year.
So this is a significant enough number of cycles that warrants further research about the safety of this practice. IVF includes 6 steps, the first being the ovarian stimulation, which is accomplished by the so-called fertility drugs. One of those, most famous one, is clomiphene citrate, which is a GnRH analog. And then, of course, there are the gonadotropins, FSH and HCG, and also the hormones themselves, progesterone and estrogen. All these hormones, through the axis depicted in this photo, the HPO axis, stimulate the ovaries to produce the hormones that regulate the menstrual cycle. As a result, the uterus responds to these fluctuations in the hormonal levels by preparing itself and actually maximizing the successful possibilities of an implantation/pregnancy. All these drugs, clomiphene citrate and also the gonadotropins, ultimately, through different processes, lead to increased amount of estrogen levels. And estrogen levels have been proved to increase gene expression, which in turn increases cell proliferation, which can be thought to induce breast cancer. However, the thinking process behind HCG is different. Breast cancer cells are known to produce HCG. And not only that, but they also have a higher amount of HCG receptors. So HCG can be recognized as a breast cancer tumor marker. And in the event of a non-pregnancy, where we would expect HCG to be elevated, this is thought to actually cause cancer proliferation. And why does this happen? There is a specific type of breast cancer, which is a hormone-sensitive breast cancer, that consists of cancerous cells with hormones for estrogen and progesterone, either one of those or for both of those. When the hormones bind to these receptors, the cancer cells become activated and can stimulate cell growth. And of course, this is a multi-step cascade with many mediators that are irrelevant for now. However, what is actually worth mentioning is that the hormone-sensitive breast cancer types are very prevalent. From all the breast cancers, an 80% is ER positive, while 65% are both ER and PR positive, and only a quarter is double negative, which is something very hopeful since these cancer types are also sensitive to endocrine therapy. So we can understand that we can target this cascade to halt the progression of cancer, either with estrogen blockers like tamoxifen or with aromatase inhibitors that will inhibit the production of estrogen in the first place. But back to IVF. Although these reports have been made about IVF, this practice, and an increased risk of breast cancer, the American Society for Reproductive Medicine reassures women that there is no cancer risk whatsoever associated with the techniques that are implicated today with IVF. And why is that? It is because of lack of knowledge and research, actually, because most studies did not manage to provide a causal relationship, to prove a causal relationship between IVF and breast cancer. However, the majority of the research and the studies did show an association, especially in women over the age of 40, in women who were followed up for more than 10 years, in women who commenced IVF at an early age, or in situ breast cancer type, and an associated increase in number of treatment cycles. And an increased number of treatment cycles has also been shown to influence the risk of breast cancer on its own as well. So, as you've probably understood, I haven't answered the question yet, and I probably won't be answering it because of lack of evidence. There is not enough data to just prove or reject this theory. However, the rates of both breast cancer and of IVF treatment cycles implemented are constantly increasing and thus warrant further research. So until then, please know the signs and symptoms of breast cancer, and also please be reminded to self-examine yourself. Thank you.
Thank you. Excellent talk. Did you find any Cochrane meta-analysis?
Yes, there was one meta-analysis, but however, it was a meta-analysis of few studies. So those results were not significant enough as well to either reject or prove this theory. And their conclusive remarks were that up until now, we haven't proved a relationship, so IVF is considered to be safe. However, we have signs and that it might play a role in some specific cases, like I mentioned in the last slide.
Okay, so probably in the
future. So they cannot cover you completely, but the data is not enough to not have IVF be considered as a safe practice.
Okay, thank you. Any questions from the audience? Yes, please.
I was just wondering, is it a conclusive because both the IVF and the breast cancer keeps rising, or there's not enough studies?
Yes, and also that's one reason, but also actually breast cancer has many various known factors. So the research that has already been done hasn't isolated one factor from the other. So some state that, okay, you've proven a connection between IVF and breast cancer risk, but you don't know if those women from your study did have, for example, a positive family history or did have other risk factors that are known to actually be risk factors for sure. So there are many reasons. And there hasn't been so much research at the end of the day, you know, in general.
So thanks again to all the speakers. This was an amazing session. We've learned a lot, and now we proceed with the. No, I think this was. There's another one, a roundtable presentation. Yeah.
Εδώ δεν παρουσιάσαμε, δεν κάναμε review της βιβλιογραφίας.
Okay. Okay, so we're terminating this one. So this is.
There is no video in the camera.
No, thank God.
No, because even though I started to speak, it was still here.
Oh, no, no, no. There isn't. And then is bottom, but she's the last person, and then also will do now the other one. And. Oh, this is so slow. Save as. Okay, download out. Yeah, I'm just downloading everything, so don't have any glitch from there. Cool. This one as well. So first is Maria, then it's
Sophie, Maria, Evita, me.
Okay, so Sophie, Maria, Evita, you. Τώρα κάνουμε, άρα πρώτα είναι η Σόφη, εγώ, Μαρία, η Εβίτα και η Ρώτα. Οκ, τέλεια. Καλό, δώσουμε ένα κατεβάζουμε τα υπόλοιπα. Καλό. Copy, download copy. Λογικά το θα κάνω. Εγώ τι. Άρα έχουμε τα όλα δαμέ. Να μπω στο digital, να τα κλείσω όταν το θέλω. Ω, εσείς θα είστε. Ωραία. So, πρώτα είπαμε είναι... Κανονικά ναι. Απλά το θέμα είναι ότι για το μόνο λάπτοπ που φαίνονται έχουμε user. Ναι, αν το πάρεις εδώ και βάλεις accept, δεν το κάνει. Ναι. Σου χρησιμοποιεί. Αλλά και τον ήξερα. Όχι. Εν το μόνο λάπτοπ που δεν λειτουργά. Δεν ξέρω γιατί. Τέλος πάντων. Ωραία. Άρα σας θέταμε. Άρα πρώτα είναι στο... Οκ. So I think we're ready. Απλά έχουμε στο κλειδί. Καλό. Άρα μια χαρά. Ψήφαμε στο και απλά λάσετε. Οκ. Ναι.
Welcome, everyone. It's with great pleasure that I introduce to the roundtable of pediatric cancer the unspoken aspect of treatment. This roundtable is coordinated by Sofia Themistokleous and is presented by Rotem Dayan, Evita, and Maria. I'll give the floor to Sofia.
Thank you very much. Okay, so today, right now, we're going to be presenting something different, something medical students do not think about very often. And that is what you can do beyond treatment. So what you can do beyond medication to help your patients, especially children, okay? So first of all, what is pediatric cancer? Pediatric cancer is basically when immature cells inside a fetus or a very young individual begin to behave in a different manner, okay? They start to grow uncontrollably, and unfortunately, we start to have some genetic abnormalities which we cannot control. Now, this brings us to the point that the pediatric tumors are actually very aggressive. So it is very important that we do identify them as early as possible so we can proceed with treatments, okay? Now, throughout the globe, there are different pediatric tumors that occur, and each one will appear differently according to the age of the child, okay? And of course, will be more aggressive depending on the genetics of the child. Now, the most common ones that we do find is leukemia that interrupts the blood, as we know, lymphoma, which has to do with the lymphatic vessels, which eventually end up in the blood as well, and the central nervous system, such as neuroblastoma. Now, why this is important to me and, of course, to your classmates is the fact that around the US, for example, 1.9 million new cases of pediatric cases will be announced in only 2023, okay? That also means that around 609,820 patients will lose their lives. Now, we are talking about children. Throughout the years, we were able to decrease the odds. Actually, the numbers you see here are relatively decreased compared to what we used to have. So where is the gap in treatment? What are we missing? Why are we only saving 8 out of 10 children, for example? What's happening to the rest? So a few studies have begun to look at why these statistics are not dropping over the years, okay, especially between the ages of 0 to 14. As you can see right here, these numbers have been collected from a paper from 2020 from the WHO, and they're still quite high. So if we can't prevent it, at least let's treat it. So in order to determine where the gaps are, we looked at the symptoms, all right? So some of the symptoms that we did find is systematic inflammation, which is one of the main ones we see, oxidative stress, which causes a lot of degeneration in the body if not treated, joint pains for the patients, fatigue, and weakness. Now, the last three, okay, they also appear because of the treatments we offer the patients. So if we're actually making their bodies weaker, how are they going to respond to the treatment that we're giving them? How are they going to respond to chemotherapy or radiotherapy? Okay, so why not try, get rid of these symptoms, or at least decrease them in order to help them respond to treatment more effectively. Now, in order to do this, the European University of Cyprus has signed up to a European project to help the community in this sense, okay? This project is called the EXIT-CAN, which is an exercise intervention in children with cancer. This project began in Greece, okay? What they basically aim to do is collect different definitions of how people understand cancer, how doctors will move forward in terms of treating their patients, what policies exist in every country, because they are different. Now, we also looked at the guidelines that they use, that they follow, and of course, if there are any interventional programs available. These are the countries that we've been collaborating with in order to identify all of the points I mentioned earlier, and of course, Cyprus is on this map because of us. And we do aim to go a bit towards the east as well eventually, okay? Now, since we're in Cyprus specifically, we reached out to many programs. For example, we've reached out to the ELPIDA program, which was one of the most involved, shall we say. We had Garaiskagion, Elpida Youth, which actually focuses on psychology, which Evita will talk to you guys about later. And we also talked to the Cyprus Anti-Cancer Society. Now, the Cyprus Anti-Cancer Society is a bit lower on the map, reason being they do not interact at all with children. And we were wondering why this is. Now, every single program you see on this list, none of them actually had policies or programs in play on how to deal with pediatric patients, which was kind of a shame to hear. Now, talking with the other countries, what we did discover, and with evidence, of course, which wasn't easy to present to you guys here, is the fact that actually exercise is very effective for the response of the patient to the treatment. We discovered that it actually improved the appetite of the patient, it improved their flexibility, their movement, their psychology overall. And it actually did help with them responding to treatment. Okay? So it's much more than what you give them on a piece of paper or what you sign them up to do. It's actually what helps if you actually work on their body, their physical state on its own. Okay? Now, what we plan on doing for the next steps is to create a manual. We've already created it in Greek, and we will be translating it to all the countries, to all the languages of the countries you saw earlier, okay? And we will be sharing this with both patients, parents, okay, and of course, the doctors. And we do hope over time, if we see positive results, we will be sharing this with the actual governments of the countries to see if we can actually put this forward as a standard manual to be used. Now, we've also discovered that some nutritional tips do help. We haven't had much research on this part, which I do hope we will have and hear about. So I do urge all of you, if you want to be good doctors, follow your books. If you want to be the best doctors, go above and beyond what you hear, because there is much more out there than what we teach you, okay? So, if you want to hear more about us, okay, we do have a website already up there. Like I said, it is still in Greek. It will be available soon in English, and we will be sharing it with you, okay? Now I'm going to hand you over to your students who will be presenting more about the matter. Thank you very much.
Hello, everyone. According to WHO, about 400,000 children and adolescents under the age of 19 will develop cancer every year. Over the last decades, the survival rate for children with cancer has increased, as well as the risk of therapy-related complications. Now, why am I telling you this? Because my objective with this presentation is to inform you about the side effects of the chemotherapy and some suggested methods for the children to overcome this and allow them to respond better to treatment. My name is Maria Chapari, and I am a fifth-year medical student here at EUC. My presentation is divided into 3 parts. The first part is about a few words about chemotherapy, the second about the side effects of the chemotherapy, and the third part about the suggested methods to overcome these side effects. Chemotherapy is one of the most common type of treatment for treat patients with cancer. The inhibition of the uncontrolled growth and proliferation of the cancer cells is achieved by the use of chemotherapeutic agents, also known as anti-neoplastic agents. Chemotherapy works by destroying the fast-growing cells. On the one hand, it will destroy the cancer cells, but on the other hand, it will destroy also the healthy cells, and this is the cause of the various side effects of the chemotherapies. The next part of my presentation is about the side effect of the chemotherapies, which can vary by the medicine, the dosage, the duration, and also by the health of the children. Most of them are temporary and will pass once the treatment stops.
The most common side effects of the chemotherapy are placed in this table, and later we will discuss how we can manage each one separately. In addition, there are some long-lasting and late-developing side effects, which are the heart problems, the lung problems, kidney and bladder problems, infertility, and some nerve damage, the risk of a second cancer, and also psychological late effects. This problem can be monitored and can be checked by various tests, such as echo, X-rays, blood, urine tests, and also pulmonary function tests. Let's move now to the next part and the last part of my presentation, which I think is the most important part of this PowerPoint, and is about the suggested methods for the children to overcome the side effects. Rest, frequent short naps, and light exercise will help with the management of fatigue in children who take chemotherapy. Exercise and physical activity during chemotherapy can improve the quality of life of the children, can prevent the reduce of physical functioning, also can prevent the medical complications, and also it can improve the effect of chemotherapy. Avoiding exhausting activities. Getting help with daily tasks from a friend or a family member, eating healthy and drinking enough of liquids will also be helpful. Nausea, vomiting, and also appetite, loss of appetite are also very common side effects of chemotherapies. In this case, it is suggested to take multiple small meals to stay hydrated, and also, if needed, to take anti-nausea medications. For the management of flu-like symptoms and infection, it is important to stay hydrated, to avoid close contact with sick people, to have a good hand hygiene and measure and monitor the body temperature, and in addition to have the annual flu shot. Neutropenic diet, which means avoiding the raw vegetables and fresh meat, can help with the prevention of infection in pediatric oncology patients. Some kids can experience weight loss and some others can experience weight gain. For example, children who take steroids-containing chemotherapy gain weight. Being overweight can have an increased risk of persistent disease and it can even cause relapse. Getting assistance in maintaining a healthy diet can maintain a healthy weight and maximizes the chance of disease cure. It is important to mention that in a mouse model, a ketogenic diet, which is a diet high in fat and low in carbohydrates, can improve the therapy efficacy for brain tumors. However, this diet to children is questionable. Moreover, nutritional and exercise interventions that target the whole family of the child can have increased chances to success and to maintain a healthy weight. Furthermore, to prevent weight loss in pediatric oncology patients, it is important to address an individualized nutritional plan according to the age, to the child eating habits, allergies, and weight and height measurements. In addition, frequent small meals, healthy snack, and sipping drinks through a straw will also be helpful. Some chemotherapies can cause hair loss, but once the treatment stops, the hair will start to grow back again. To manage this side effect, it is a good idea to use a mild shampoo with sunscreen to prevent the sun damage. It is a good idea to have a haircut or shave the head prior to treatment, and to wear hats and scarves, and also use satin or silk pillowcases. The risk of anemia can be reduced by consumption of food high in iron. If the red blood cells are significantly low, a blood transfusion may be given. Thrombocytopenia is when the platelets count in the bloodstream is low, and this can lead to bleeding. It is important to avoid rough play and contact sports. In addition, soft toothbrush and electric razor can be helpful to avoid unnecessary bleeding. Headaches, muscle, and stomach pain can be managed by using over-the-counter medications. To prevent and manage the mouth, the gum, and throat sores, it is suggested to use a mouth rinse to avoid high acid foods and juices, and also to brush the teeth more frequently. Sometimes laser therapy is also useful because it can stimulate the healing. Constipation can be managed with high in fibers food, hydration, light exercise, and if needed, with over-the-counter medications such as laxatives and stool softeners. On the other hand, in case of diarrhea, the child must drink adequate amount of liquid, avoid spicy foods, and foods which contain high amount fibers and fat. If needed, they can take also anti-diarrhea medications. Skin changes and especially skin irritation is also seen in pediatric oncology patients. Wearing loose and soft clothing, using sunscreen, and keep the skin moisturized are some of the preventing measurements. The risk of forming blood clots in children who take chemotherapy is increased, and this subsequently increases the risk of a stroke. To prevent and decrease this stroke, it is important for the child to drink enough fluids and also to walk around. This brings me to the end of my presentation. To summarize my points, chemotherapy destroys not only the cancer cells, but also the healthy cells, which is the cause of the various chemotherapy side effects. Chemotherapy side effects are a lot and must be managed to allow the children to respond better to the chemotherapy. Hydration, nutritional, and exercise intervention are the most important methods to overcome these side effects, actually the majority of these side effects, and can improve the effects of chemotherapy. Thank you all very much for your attention.
Okay, this one, right? Thank you, Evita. Okay, Evita's going to take over now. Do you guys have any questions for Maria before we change? No? Perfect. Thank you.
Okay, so we already talked about the therapeutic aspect in terms of chemotherapy when it comes to pediatric cancer patients. And I'm going to talk about a kind of neglected subject, which is the mental health aspect and the psychological support. It's what we call pediatric psycho-oncology. So some demographics about pediatric cancer. First of all, approximately 80% of children with cancer are cured in high-income countries. The percentage for low-income countries is way lower. So that means we have a lot of cancer patients, pediatric cancer patient survivors, who have undergone through this very traumatic period of their lives while they were able to undergo their disease. And when it comes to pediatric cancer, 28% of the cases account for leukemias, with the most common ones being ALL, acute lymphocytic leukemia, and acute myeloblastic leukemia. Now, a very important percentage here is this one here, that 89, almost 90% of cancer patients who are 5 to 12 years of age will develop in the future at least one psychiatric disorder. So that means that there is this demanding need for psychological support and to create a standard in order to have this type of mental health management of those patients. So this is how pediatric psycho-oncology comes in. And especially according to WHO in 2023, it's estimated that 10,000 children younger than 15 years old in the United States will be diagnosed with cancer. And as I said, we have a high percentage of patients who actually are able to be cured. That means that we have a lot of survivors. That means we have more people going through psychiatric conditions, maybe in the future, or the close proximity family members. So some more demographics when it comes to psychiatric disorders in pediatric cancer. 48% of children and adolescents with cancer met the criteria for depressive disorder, anxiety disorders after they've been diagnosed 12 months post-diagnosis, which is actually called the diagnostic shock point. It's this period of their lives where they tend to have this existential, physical, and psychological struggles, and they're not being able to adapt to their social environment. So they're not able to go to school as they used to. They're not able to play with their peers as they used to. And of course, it's also a crisis for the parents as well, who are the primary caregivers of the affected child. So what is pediatric psycho-oncology? It is a branch of pediatric psychiatry and health psychology that deals with the emotional and behavioral aspects of children with cancer. And how does it work? So it identifies and manages the psychiatric comorbidities during cancer care. So it optimizes the medical outcome in terms of adherence to the treatment as well, because a lot of the patients, the pediatric patients, come to a point to refuse the treatment, and also in terms of rehabilitation. And also, we have to address the parental concerns of the parents and empower the primary caregivers who are going through this very hard period of their lives. Now, most large oncology centers, they really do have mental health professionals in the oncology department. However, it's not universally available around the world, and there is no standard of care when it comes to psycho-oncology. Now, how can psychiatry can be integrated with pediatric cancer care? The standards for psychological care for children with cancer and their families that was established in 2015 states that both the youth with cancer and their families have to routinely and systematically go through psychological assessment during their treatment and whether there is survival during that period of time. And especially the high-risk patients to be routinely monitored for some neurophysiological deficits. Now, the most common psychiatric comorbidities with pediatric cancers is, first of all, procedural anxiety. Of course, children, as they go through some procedures, they become more afraid of them, and they might also develop in the future generalized anxiety disorder. Then adjustment disorders is what I talked about before, how they're going to be able to cope with their everyday lives and go back to their social cycle normally. And then depression, which has both a psychological and also biological correlation with cancer. Agitation and behavioral difficulties, neurodevelopmental disabilities, body image problems. A lot of patients have established to have eating disorders after their survivorship from cancer. And something I want to point out, another major issue is substance misuse, which has been a major issue, especially in the US with the opioid epidemic. So these patients should be very monitored in terms of the opioids they take for pain management, and there are specific programs for them. So we talked about procedural anxiety, fear of procedures, generalized anxiety. The adjustment disorders, you lose contact with their peers or disruptions in their school attendance, or they're overwhelmed with the diagnostics, what we talked about, the diagnostic point. And then the depression, it can present as agitation or as absence, and there are a lot of clinical trials that are absent in terms of depression. So there are some hypotheses of the pathophysiologic mechanism that I'm going to show you afterwards. And finally, the neurodevelopmental disabilities. So children maybe previously diagnosed with autism spectrum disorder or some developmental delay. And here is what I told you about the depression pathophysiology. It is a cycle that the one causes the other, cancer and depression. So it's mostly a neuroimmune and endocrine system dysregulation when it comes to the sympathetic and parasympathetic dysregulation, the stress-induced HPA axis activation, and the dysregulation of some pro-inflammatory cytokines as well. Finally, another issue in psycho-oncology is children with brain tumors who will present with some neuropsychiatric deficits or some comorbidities when it comes to their own condition. Now, what is the treatment that is proposed? As I said, there is no standard of treatment. However, behavioral management and CBT or behavioral strategies, because some children are very young to get into cognitive behavioral therapy, so keeping diaries, teaching progressive muscle relaxation, have guided imaginary of positive self-talk, and of course planning a family session, so family therapy structured, there are a lot of family therapy structured at schools or in hospitals, mostly abroad, not so much developed here in Cyprus and in Greece. And then we have the pharmacological treatment, which is besides the constant treatment, which is for the psychiatric disorders like psychotropic medications that can be useful in treating anxiety. Finally, I'm going to talk about the approaches of the pediatric palliative care. So the WHO defines pediatric palliative care as the active total care of the child's body, mind, and spirit, giving support to the family. And healthcare providers must be very connected and have an honest and evaluate and alleviate the child's physical and also psychological distress as well. So addressing the child's and family's spiritual needs is also very important to the psychological part as well. Addressing the financial burdens of the family, which can also kind of shift the dynamic of the family, providing support to the siblings, and providing bereavement support to the family after the death of the child, which is very important. So following the death of the child can be both debilitating for the patient, for the parents, for the siblings, and for the physicians as well. So there should be an ongoing mental health support for the siblings, as well as for the physicians. As the American Academy of Pediatrics has recommended, the physicians should receive ongoing psychological and ethical spiritual support to assist them with the stress that they're carrying when a child in the hospital department has died. And that concludes my presentation. Thank you very much.
Perfect. Does anybody have any questions for Rita? Excellent. Now we're going to move on to Rotem, who's going to present
she has a question.
Palliative care, it's in a sense that the child cannot survive. So, yeah. You mean the family? And usually you have to provide either family therapy or psychological therapy to the siblings, especially if there are any. And if I were to tell it, something very common actually for parents is that they think they should have done something right or they should have done something earlier. So I think that something that you should have definitely made clear to them is that they did everything they could, and especially ALL, acute lymphocytic leukemia, and AML mostly, is very unpredictable. So a child can go just over a night by DIC, disseminated intravascular coagulation, and usually the parents have this kind of burden and they feel like it's their own fault. So I think that's a very important point there, to make them sure that they did everything they could. And you also suggest to them that maybe they should, if they're not in therapy, they should have some kind of psychological support if there are any siblings in the family. And yeah, I think that's the most important things I would say to a patient.
And also to keep in mind, for some hospitals, it doesn't exist for all, they do have a protocol. If you're going to deliver news like that, you need to do it in the presence of a psychologist next to you, okay? So you do have to do that. Now, Rotem is actually going to present to you how, as medical practitioners, you can come close with the community to help these patients and their families. Okay, Rotem?
Thank you. No? Okay. So, like Sophie just said, my part will be actually to conclude what of the three before me said. I have been volunteering with Larger Than Life, which is a foundation that is in Israel, where I live, where we take care of, it's not much of the pediatric cancer, it's not the kid itself, it's more of a holistic, we see them as a family, we have a lot of aspect we approach, and a lot of them were discussed here before, which we kind of give an answer to. So, what is Larger Than Life? The vision of it is to improve the quality of life and well-being of children and cancer and their families all over Israel, regardless of region, gender, or nationalities. So basically what this means is that this foundation is not the doctors who give you the treatment. This foundation is the one that see you as a whole, see that there is a distress, and try to reach from a different angle. This foundation actually was built and funded by parents of cancer patient. They decided they need more than just get treatment. They decided they need more support. They need some kind of a community. So they built this foundation, and I had the great chance to be part of it. So, how do you do this? How do you get them better? How do you improve and support them? So they have a few fundamentals. First is hope. Second is health. And third is happiness. So what does it actually mean? This is like great big happy words. So health. I'm going to give you a brief points of each aspect because there's many, but I hope you will get an idea. So as far as health, I mean, it's not contained of doctors, but what can we do that is supporting health? So the foundation actually funded treatment that are not included in the health insurance. They also travel the patient to abroad to get the treatment they need to. They also transport the patient to the hospital. So cancer is not a month or 2 months disease. It's a full time. It takes years. And the parents can't just stop working out of a sudden. So they need to have a support system. They need someone to take the kid to get treatment. They need someone to be there in the hospital because the parents cannot do this all the time. So we do have transportation. We do have people who take care of the kids or take care of the family. As for hope, Larger Than Life has the first world sterile educational and recovery center. That means we have the kindergarten of dreams. It's the first kindergarten which is sterile because like they said before, kids that has cancer are immunosuppressed. They cannot go to a normal kindergarten. They cannot go to a normal school. So what this means for them, they cannot go outside of the house. They don't have a social life. They don't have anything. They are being lack of development because this is the crucial years of your life. And if you don't have the support, you don't have someone to teach you the milestones in kindergarten, you're stuck. And not because of the cancer, because what it comes with. One of the other things they do is to increase the public awareness and the difficulties, if that includes legalize more crippleized support. So people will be aware because a lot of them are being crippleized because they need to take the limb out. They need to be having procedures and they have mental deficit. So they do bring more to the awareness of that, so they will have more support. Finally, and this is my major part of the foundation, it's happiness. So like they said before, especially Evita, the social aspect of cancer kids, they're being isolated. They're being out of the society, and even if they keep having their circle of friends, their friends don't understand it. It's not something obvious to understand what is cancer, what it is to live with. I might die tomorrow. My friend just died. But in Larger Than Life, you do have the people around you. There is a support group, and not just for the kid itself. You have the support group for the mothers, you have the support group for the fathers, you have a support group for the entire family, because it's a whole, because it's not one kid that has cancer. When a kid has cancer, the entire family has cancer. So the part I have been participated for this last 7 years, we have a summer camp for school-age children. So like I said before, they cannot go for a normal summer school or a normal summer camp. They can't. They had to have a place that knows their needs, a place that can support if they need a medical attention right now. So that's what we have. We have a vast majority, like a vast, very extensive medical support. We have people who knows what cancer looks like, what cancer feels like, what cancer sounds like. So we have around 200 children, and it's not just the children, it's also their siblings. Just to make sure that the sibling who does not get the attention at home because he has a cancer sibling, and they don't get enough living normally because they constantly being afraid of their cancer sibling. So we treat them all together as the same. I don't care if you have cancer and you are not, you're the brother of someone who has cancer. You're all kids, and that's how we treat them. So they have the experience to socialize, to see people who are just like them. We have conversations about cancer, about what drugs do you get? What was the worst part of cancer for you? So that's the kind of conversation we get to have in the summer camp. Another aspect of the summer camp is that kids that have cancer a lot of times are scared to trust their bodies. Or a lot of times they are being retrieved from their independence. So they are in their teenage years, they're supposed to be more independent. They're supposed to get out and say, okay, mom and dad, I don't need you anymore. But then they are, and then they need them. And then they cannot be alive without them. They cannot do basic function anymore. So then they go to the summer camp, and I have seen many times where a kid come and say, you know what, I want to take my own drugs. I want to be responsible for my own schedule of taking my drugs. I have a kid that says, you know what, I want to give it a try and change my own stoma. So they take responsibility over their body. They say, I want to climb this wall. So we have the physical activity, we have a lot of activities during summer camp, and they say, I didn't think I'm going to manage to climb it. I didn't think my body can sustain it because they're weak, they're tired, they're exhausted, and they try. And then they succeed, and they gain their trust in themselves. And finally, we also have a summer camp for the tiny ones. So it's from 0 to 6. This summer camp is with the families, which give us the opportunity to take for a second the cancer kids from the family. And then you have the other interaction. You give them a moment of vacation, which they don't get much. You give them a moment of being normal, of being supervised in a very, very safe environment, and just be a family for a second. It's nice, it's cute, and it's pure joy. So, some numbers. We have 14,854 children and families receiving guidance and support from the Associated in 2 decades of activities. 23,654 children with cancer and their families receiving the support and association of and participating in our activities every year. We have 768 social and leisure activities, and 365 new volunteers are joining in Larger Than Life every single year. So, you know what they say, laughter is the best medicine. So, thank you.
Any questions? Okay, thank you very much for listening to us. I hope you understand now that being a medical practitioner doesn't just mean giving your patient a diagnosis and your work ends there, okay? Your patient needs a lot more from you. They need advice, they need help, and they need guidance. And as all 3 of your classmates mentioned here, it makes a difference in their life and they need it. And given the statistics we gave you, there's a lot of children out there who don't have a normal life, and they can have one. So make sure you give them as much information as you can so they can live as much as they can of their lives. Okay? Thank you very much.
army now.
Evita, we go here next to the piano. Ah, okay. I didn't understand.
Δεν φαίνεται να μην δεν έχω νότς. Αν είναι κάτι το σύστημα να έτοιμο γι' αυτό. Και αυτό θα κάνουμε αυτό που θα είναι πάρα πολύ βάζουμε αυτό και να
Okay, let's try to... Huh? In what better way? I'm gonna laugh myself off.
It's fine, it's very fine. I mean, it's already
Hi,
possible.
Vita. She wants. Sabrina. I'm gonna be like this. Hello, good evening everyone. I'm Avram Cassuto, this is Evita Veriza. We're here to welcome you to the new edition of the Cyprus Annual Medical Students Meeting, also known as CAMeSM.
It's our honor to host this event created by students for students, and we are very excited to start CAMeSM again. After 4 years, it was paused due to the pandemic. And this year, we also joined forces with the School of Dentistry, who has provided a tremendous support in the organization and everything with the medical sciences.
Today's ceremony is a celebration of the spirit of collaboration and camaraderie that is at the heart of CAMeSM.
We have a fantastic lineup of speakers and events for you today, so we hope you enjoy it.
No better way to kick off the ceremony with a musical performance by our own student band composed of medical and dental students. Please, a round of applause. Congratulations to the bands, that was amazing. Really good song selection. Another round of applause for the guys, please. It's now time to welcome our esteemed guests who will share their valuable insights with us.
We would like to welcome Rotem Dayan, our co-chair of the CAMeSM, to come to stage and say some words of wisdom.
Hi. So, my name is Rotem Dayan. For those who don't know, I'm a sixth-year medical student. I would like to start by saying hello to everyone. This is really important for me. So, Director of the European University, Professor Efthathiou, dear Professor Gravanis, our keynote speaker, dear Dean of School of Medicine, Professor Johnson, and Professor Nikousis on behalf of the Dean of Dentistry. Dear professors, staff, and fellow students, ladies and gentlemen, welcome to the 5th CAMeSM. This Congress journey started 3 years ago, back in 2019, when I received someone else's dream into my hands. I was then a third-year medical student. I didn't know much. Unfortunately, due to COVID-19, we had to put that Congress on hold until this year. Now, this is my dream. This is my baby. And I'm a sixth-year medical student. I'm a wiser. I learned, I've grown. And together with my incredible team, we have managed to take CAMeSM into a new level, restating CAMeSM into its place in the EUC academic calendar. Looking at our journey, I'm excited to see what the future will hold. For me, CAMeSM is more than just scientific congress. It is our motto, from student for student, which means we're here to share the knowledge we would want to learn in the way we would want to be taught. This is the opportunity for us, the student, to be the better version of ourselves. It is our place to invent, to explore, to be extraordinary so early on in our career. Everything that you see in these 2 days was thought, built, created, and delivered by a student, including the student band you just heard, the presenters, the workshops, public health stand, organizing committee, which worked months to make this Congress happen. And of course, like everything that is good, my co-chairs, Valerie Gorklo and Daniel Carney, which I could never be here without them. So, as you all can see, it really does truly take a village. I had the opportunity to be mentored by inspiring faculty members who gave their valuable time with nothing in return except the knowledge that they would make us better. Working alongside incredible students who taught me every single day, and to experience how much talent and willingness we have among our students. I would like to thank you all for that. I'm grateful to be privileged to take part in this Congress, and thank you for coming, and I hope you will continue to enjoy this Congress.
Thank you so much, Rotem, for the speech.
So next we will have the privilege to hear from our esteemed guests who have made this Congress possible. We would like to welcome Professor Johnson on stage, our Dean of School of Medicine.
Rotem said something that stuck in my mind, to be extraordinary. Well, first, it was an extraordinary band. Well done. And it's an extraordinary meeting. Dear Rector, my dear friend and colleague for too many decades to count, Professor Gravanis, Professor Nikousis, faculty, distinguished guests, and of course, my dear, dear students. It is with true pride that I welcome you on behalf of the School of Medicine to the Cyprus Annual Medical Students Meeting, which hasn't been annual, 2023. While this may technically be our 5th CAMeSM, it is the first true students' meeting, a meeting by the students, for the students. It is the first time that you, the students, will speak and disseminate state-of-the-art knowledge in roundtables, free papers, and what other presentations that you may have that cover a wide gamut of topics: internal medicine, oncology, dental aesthetics, I saw, and much more. To achieve this, you worked together and you worked with your faculty. In addition to being exposed to new knowledge, you're given the chance with this program to enhance your skills in hands-on workshops, ranging from EKG tips and tricks, basic laparoscopic surgery skills, we know where that came from, suturing, and implant placement for the dental students. I mean, the list was amazing. The choices were amazing. CAMeSM has now become a platform to embrace research. The faculty of both of our schools, medicine and dentistry, and I hope next year to the next coming organizing committee, health sciences, believes that research in its broadest sense is a valuable asset to our undergraduate medical and dental education. We believe that even at the basic level, engaging in research helps you realize that knowledge is not just an inert principle, that it's passively received in a lecture, but it's constantly created, debated, reformulated, and shared. And that is what you're doing here. I think it has become clear to you why student meetings such as this are so vital, so important. First, they give you the chance to contribute, to learn as well of the most recent advances in your field. Secondly, it helps you to develop a very important skill, the art of communication, how to talk about your data, your findings in a clear and meaningful way. Something that, with the quality of the round tables and presentations that we've seen, we've been very impressed. Third, your experience in these meetings help you develop leadership skills and the ability to advocate your science fairly. Congratulations to all of you who took the nerve to step up and stand on the podium to this challenge and play a role in this meeting. Hopefully next year, more of you will do it as we revive the CAMeSM meeting. Congratulations to the organizing committee for making today a reality. And I want to stress, they did it on their own. It is something that they did with you, putting this meeting together. Together, at this CAMeSM meeting, you have begun to create a platform of a strong global science. You represent the entire globe. Our School of Medicine and Science and Dentistry, 70% of you are from other countries outside of Cyprus and Greece. You represent a global network. Here is where you're building that global network. Your future friends, practitioners, researchers, explore and develop your academic knowledge within this network. I have no doubt that this will be the beginning again, the rebirth of CAMeSM. The 2023 meeting will put us back on the milestone and framework. Congratulations, and as Rodham said, you are extraordinary. Well done.
Thank you so much, Professor Johnson. Thank you. Next, we would like to invite our Professor of Histology, Embryology, and Oral Pathology, our dear Professor Elpida Nicolosi.
dear Rector, dear Dean of the School of Medicine, Professor Johnson, dear distinguished invited Professor Gravanis, distinguished guests, dear students, ladies and gentlemen. On behalf of the Dean of the School of Dentistry, Professor Athanasiou, I would like to extend a warm welcome to the organizers and to the participants of 2023 Cyprus Annual Medical Students Meeting. The School of Dentistry of the European University of Cyprus has encouraged its students to actively participate at this great event and noted with satisfaction the supervision and preparation of their presentations by our academic faculty. The Cyprus Annual Medical Students Meeting provides health science students with the opportunity to experience their participation as presenters or attendees at a well-recognized scientific event organized by dedicated young people in a professional way of high standards. Oral diseases are a major health concern that negatively impact people throughout their lives. Oral diseases lead to pain and discomfort, social isolation, and loss of self-confidence as well. And they are often linked to other serious health issues. And yet, there is no reason to suffer. Most oral health conditions are largely preventable and can be treated in their early stages now. The presentations of our students will refer to several dental disciplines, will contribute to a better understanding of the biomedical foundation of our science, and hopefully will empower the participants of the meeting with the knowledge and confidence to secure good oral health. Focusing on the importance of oral health at every stage of life should be the message of the dental presentations, because no matter what age you are, caring for your mouth and looking after your oral health is important. The School of Dentistry is confident that the presentations of our students will successfully serve the scope of the 2023 CAMeSM, extends its warmest congratulations to the organizers for materializing such a demanding task, and also wishes great success to the event. Congratulations to all. Thank you very much.
Thank you, Professor Nicolosi, for your wonderful speech. And now moving on, we want to go to Andreas Evstathio, our rector of the European University Cyprus, to join the stage, please.
Good evening, everyone. Many thanks to the band from me as well. I really enjoyed it. It was great. Thank you. Dear Dean Johnson, dear Professor Nicolosi, our distinguished guest, Professor Gravanis, dear colleagues, and of course, dear students, it is my great pleasure and honor to address you this evening on the occasion of the opening ceremony of the 5th Cyprus Annual Medical Students Meeting, CAMeSM. It is extremely satisfying indeed that we see this meeting, this successful meeting, being organized again on our campus with physical presence after the COVID-19 period. The aim of this series of meetings is to provide a truly unique experience to medical and dentistry students of our university, as one of its distinct features is that it is a meeting organized by the students for the students. The meeting gives the opportunity to students to get experience in presenting their work, but also to connect, network, and form lasting relationships and friendships with other international students and recent graduates. I'm pleased to see in the program of the meeting numerous activities that will give to the students the opportunity to present recent work and ideas in the areas of medicine, dentistry, and biomedical research. It is also very important that former students from a number of different nations who participate in this meeting will be able to share their experiences post-graduation with the students and provide guidance for the career decisions they will need to make soon. I would like to take this opportunity to say a few words about our university, our achievements, which I think may be of interest to all of us. As you probably know, our university has its roots in Cyprus College, which was founded in 1961, only 1 year after the founding of the Republic of Cyprus itself. We are therefore very proud that it ranks as one of the most historic academic institutions on this island. Our institution has, of course, come a long way since its founding, more than 60 years ago. An ever-increasing number of our faculty and researchers collaborate with scientists in some of the finest universities in the world. Our faculty also coordinate or participate in a number of prestigious projects which are funded by the European Commission, the Research and Innovation Foundation here in Cyprus, and numerous other funding agencies. Significantly, our research activity in the last 5 years increased at the average rate of 20 to 30% per year, quadrupling external research funding and publications in peer-reviewed journals. As a result, the university already fulfills the criteria for entering prestigious rankings, like the Times Higher Education World University Rankings. We believe this is an important development which will benefit existing students, but also alumni in their careers. We also believe that a good ranking of this university will act as a catalyst for attracting new talent to the university and leading to further development and achievements. At a time when international security and stability are at risk following the first major conflict in Europe after the Second World War, European University Cyprus reaffirms its commitment for international collaboration and welcomes students and academics from all over the world. We are also very proud of the fact that our university this year began the offer of its program in medicine at the branch of our School of Medicine in Frankfurt, Germany. It is a great honor that this is the first time a university based in Cyprus is offering programs of study outside the island. I would like to conclude with my warm thanks and congratulations to all those who worked so hard for the organization of this meeting, and especially the organizing committee. I would also like to thank the deans and faculty of the schools of medicine and dentistry of our university for encouraging and supporting the students in this event. I would also like to take this opportunity to wish all of you success in your studies and your careers. Best wishes to all for a successful meeting. Thank you very much.
And now we come to the prestigious highlight of our ceremony. Our esteemed keynote speaker. We're honored to have him with us today, a true pioneer in the field of drug development and the study of human pathophysiology.
He has revolutionized the way we design drugs and the way we do tests without needing further testing with animals.
He has over 259 publications and has been at the forefront of developing human organs on a chip technology, mimicking human tissue more accurately than an animal test or 2D cell cultures.
It is our great pleasure and honor to welcome Professor Xenografts to the stage.
So, can you help a little bit with the... And how I move all the slides.
This is how you change them.
Thank you so much. Thank you. Oh, guys, I feel so moved. I cannot express how moved and honored I feel with your extraordinary invitation to be with you today. This is a medallion for Achilles. I gave so many presentations, Elizabeth, you know, for almost decades. But this is an exceptional invitation, and I do thank you for my bottom of my heart for that, indeed. So today I'm going to give you one of the many examples of how the modern medicine will be in the years when you will subscribe and do operations or diagnosis compared to my years. And the message I want to give you is that in the years that come as physicians, you will have to deal every day with scientists that, as a first view, have nothing to do with medicine. Computer guys, laser physicists, chemists, biologists, because our science changed a lot the last years, and we have now the deep science to help our patients better and to be more effective in our daily medical life. So one of the big problems the last decades, is that we have very effective medicines for experimental animal models, but unfortunately, only 1 out of the 10 effective compounds in animal models proves itself effective in humans. This is a big, big, big fail. You know, we know that the last 30 years, the pharma companies lost almost $300 billion. This is a big amount of money and has lots of changes in contemporary medicine. You know, because all this money finally increase the final price of the medicines that got the permission to get prescribed. Another big problem is that many patients out there are anxious enough and wait for new medication, and they are despair. The new technologies gave us the way to bridge this gap. And we have now different platforms to go from the animal models to humanized, human platforms, human models, before we go to clinical trials. So imagine the situation, you have 10 very effective compounds in rats, you go through these platforms, and you prove finally that only 1 or 2 of them have some substantial chances to get effective in clinical trials. This is a very, very big change. We have 2 types of such platforms: the static microphysiological human 3D cell chips, cell cultures, and the dynamic microfluidic human organ chips. The static microphysiological 3D cell chips are microengineered tissues and organoids grown in 3D gels with an ability to recapitulate tissue histogenesis and biological functions, including drug metabolism and cytotoxicity responses, modeling various diseases, and I'll give you some of examples on this stage. And they are powerful tools to dissect the molecular basis of developmental control, as well disease pathogenesis and mechanisms, and may help to replace some animal studies from particular applications. Of course, they have their limitations. They do not replicate vascular perfusion, interstitial flow, circulating immune cells, critical for accurate mimicry of the delivery and absorption, distribution, metabolism, and excretion of different medicines. On the contrary, the dynamic microfluidic organ chips, they are fabricated chips. They are fabricated using a soft lithography-based manufacturing approach adapted from the computer microchip industry. They are organ, human body on chip systems, have been created to study organ physiology, drug responses by adding fluidic coupling, vessels another way, to culture chamber bioreactors containing within their microwell system. The experience we have with all these platforms in Crete and in Boston are three types. The first one is 3 silicon scaffolds. They have very interesting electrical conductivity properties, so they can be very useful for fast electrophysiology recording. Solid for monitoring on robotic arms for high throughput screening for new drugs. The second platform is 3D collagen scaffolds, soft and transparent for microscopy and cell sampling, organ-friendly for transplantation in humans. And one of our work we are doing in Crete is to develop neuroimplants to try to reverse the damages in spinal cord injury in paralyzed patients. And the third one, the most important I think, is 3 microfluidic chips with dynamic culture conditions, true perfused organ type setup. Let's see the first platform. Look at the technologies we are using to mimic human physiology. We design actually the chip on a CAMCAD computer. Then we link this design. We can do whatever we want there in different setups. Then we link this computer to a femtolaser beaming. And we have a small junk, very solid junk of silicon, which is sculptured, microsculptured, micro-patterned by femtolaser technology, and we can give them specific properties so they can, these scaffolds can afford specific cell types, trying to mimic what is happening in human tissues. With femtolaser technologies, we can shape really very elegantly the surfaces within this sponge. Is a silicon sponge with cavities in there. So the cavities become very friendly for human cells. And not only that, but each cavity has specific micropattern properties, so it can afford different types of cells. So because the organs possess different types of cells, we can take profit of this technology and within a sponge, silicon sponge, have different type of cells. And we'll see some of these examples. This is an electron microscopy picture of a superior cervical ganglion within this scaffold, and you see in the right photo the neuronal axis well being within this structure, and you can culture this cervical ganglion by weeks actually. So you have the possibility to expose this platform with human cells of different types, neurons, astrocytes, microglia cells, expose them to different medicines, potential medicines, which are very effective in animal models, and then trying to find out how this tissue behaves. It's the target tissue for a specific, actually, therapeutic. You can mimic, simulate what is happening in different types of ganglia or neuronal tissue junks, and give properties depending upon the micro-patterning of these scaffolds, which resemble exactly what is happening in vivo. But you have all the structure outside the human body, and it's of human origin. The second platform is with human collagen type 1, mainly type 1 collagen, and we use different bioengineering methods to give specific properties of these scaffolds. We use microfibrillar type 1 collagen, and we polymerize it in presence or absence of different chemicals, so to give specific physicochemical properties. And at the bottom right of this slide, you see a picture, an electron microscopy picture of how these scaffolds look like. This is a collagen scaffold hosting a neurosphere, and this is a typical, actually, picture of neurosphere containing stem cells. And when you leave this neurosphere within this scaffold for weeks, you get neurons. And in the next slide, you see a neuron already developed within this structure. You see the soma and the neuronal axis. And this type of newly fresh neuron is very effective and very functional. You can do very important, actually, ex vivo studies for drug development. This is another photo showing that the micropattern, how you prepare the microarchitecture and the surface chemistry of these scaffolds can host different types of neurons. So you have a scaffold which has different regions that host different types of cells. You can do very elegant electrophysiological studies with this scaffold. And at the right part of the slide, you see a neuronal stem cell that is differentiated toward neurons and has the specific pattern of action with calcium. We know very well that a neuron, when is differentiated, increases its oscillations with calcium. So you see a human, actually, stem cell differentiating in vitro ex vivo towards a neuron. You can play with this structure and have very elegant and very effective, actually, neuronal networks. And playing with this structure, you can, again, try to use ex vivo this neuronal structure networks, very functional, to study pathophysiological conditions in various, actually, human diseases of the nervous system, or afterwards test for medicines that are very effective in small and big animal models, and choose which of them will go into clinical trials. And I will finish with the most important of all these platforms, the 3D microfluidic structures. This is a very, actually, important work that has been done the last 7-8 years in this institute from Harvard Medical School. And the slide represents how this very dynamic, actually, microchip for human organs works. You see how we design and we construct this scaffold. We have, of course, the channel layer, different channels that can host different types of human cells and neurons. And in the next slide, you will see how a human brain on a chip works. You have the chip, which is a small one, actually, and you have the possibility to have entry within the chip of a specific liquid. And by this way, you can perfuse and mimic what is happening in real life in organs. You have the blood that comes in, that blood that comes out, and you have phenomena of infusion, perfusion, collection of the different type of liquids that come out of the chip, and of course measure different parameters, biological parameters or electrophysiological parameters. And you can do real time, the same time you infuse and collect biological studies and pharmacological studies of how the human tissue that is within this chip behaves. You can measure with 2-photon, for instance, microscope, real time how the cells differentiate and interact between each other. You can get a small sample with laser micropuncturing of tissue, extract RNA, and deep sequence this RNA, and you will have real time in link, in association with the imaging of gene expression. And of course, you can record with micro recorders how this neural tissue behaves in control studies or after excitation or blocking with different potential medicines. And this is happening in a small chip, and this is happening on a platform of human origin. It's not an animal anymore. In the right part, you see how the chambers are structured. You have a bottom structure, which is the structure of the blood, which will perfuse the upper one. The bottom structure from the upper one is separated with a membrane containing pericytes. Pericytes are endothelial cells, and they are the main component of human blood barrier. So you have on chip something that resembles what is happening in the brain. You can prepare disease-specific chips. You can prepare, as you will see, a chip to mimic, to simulate Parkinson's disease or neuronal inflammation. And this is a chip that can give you information on pathophysiology of these diseases, or use them to test new medicines on these diseases. On the upper side, on the upper channel, you can add human cells, neurons, astrocytes, Schwann cells, or microglia cells. And these cells are coming, again, from another technology that help and will help a lot modern medicine, human-induced pluripotent stem cells. And we have now the possibility to get human stem cells, human neural stem cells, for instance, by ourselves, by isolating adipose tissue from our belly, dedifferentiate them towards neural progenitors or microglia or astrocytes, and use a chip which is personalized to us. So in the future, in the near future, we will have human organs on chip for a specific patient or for a specific group of patients with a specific genetic actually background. So imagine how drug development and pathophysiological studies will work in the years when you will become physicians. This is the chip we've developed in Emulate. Emulate is a spin-off company of Weiss Institute, Harvard Medical School. And all these studies were performed by Sifis Pediatritakis, one of my PhD students in Crete. And Sifis is now a prominent, actually, young scientist in Boston. And he's developing this type of technology. Sifis prepared a human chip mimicking blood-brain barrier, human blood-brain barrier. Another problem we have is that, the brain, the human brain, is completely different of what is happening in small animals. And the blood-brain barrier, human blood-brain barrier, is equally different. So if you have a small molecule and you give 10 years of your life to develop a very effective molecule, small molecule or a big biologic for small animals, then you have a very bad surprise when you go into humans. Because sometimes this small molecule, which is bioavailable within the brain of the experimental animal models, don't enter in human brain. So you work for many years having a very effective compound in animals, which is not effective, is null for human brain. This type of platforms will help us to find out which of the compounds that are developed in animal models have good chances to get into the brain. And if you have a therapeutic target within the brain, is a prerequisite to have a possibility to develop a drug for human CNS. One of the questions you would give me is, okay, you do a human organ on a chip, an explant, an ex vivo organ on a chip. How do you know that this organ represents very effectively, simulates what is happening in vivo in humans? For instance, in a specific brain region like the substantia nigra, very important for Parkinson's disease. So we do the following trick. With the system I gave you, we isolate a small part of the tissue within the chip. We prepare RNA, and we sequence 23,000 mRNAs, and we compare the pattern of expression of this expression with the expression that we are getting from, for instance, from protein database of what is happening in vivo in humans. You may know that we can already isolate the small regions from the brain, and not only, from other human organs. We sequenced thousands of genes, and we know, for instance, at the basal conditions, post-mortem, or in specific medical conditions, like the Parkinson's disease, for instance, what is the genetic profile of expression. So you will have a very elaborate, actually, biological trick to compare how close you are within what is happening in humans in vivo. This chip represents a simulation of human brain neuroinflammation. Let me tell you two things from our work. I'm working for the last 20 years on neurodegenerative diseases and neurogenesis, in other ways, how we can replace neural tissue with fresh tissue using the technology of neural stem cells. It is a pity, and this is a very important field for research for all of you, to find out the mechanism by which we suffer from neurodegenerative diseases. Guys, we don't know what is happening, what is the etiology of none of these human neurological, neurodegenerative diseases, except some diseases that are related to only one gene, the monogenic diseases, like the chorea of Huntington, for instance. But for the others, multiple sclerosis, Alzheimer's, Parkinson, we don't have the slightest idea what is the beginning of the disease. So using this type of technologies, we can simulate and dissect all these potential mechanisms and try to simulate what is happening ex vivo and find out physiological mechanisms that we cannot explore in animals because we are different, or for ethical reasons, we cannot explore it in vivo in humans. For the neuroinflammation chip, you have the bottom vascular part of the chip. You can infuse in there inflammatory factors, for instance, TNF-alpha. TNF-alpha we get through the pericyte membrane within the upper part of the chip, containing different types of neurons and supporting cells, microglia, astrocytes, and find out on a human pattern how this tissue behaves after different stimuli. And playing with different stimuli, we can isolate stimuli that may be of extreme importance for the pathophysiology of the disease, because the upper part of the chip will give you responses that resemble what is happening in humans in vivo. We have used this blood-brain barrier chip to test one of our very important compounds, a synthetic microneurotrophin. Microneurotrophies are extremely important for brain physiology from all our lifespan, from our first days within our, as fetuses until we leave this life. If you lose in production within your nervous system of these extremely important biologicals, microneurotropins, your neural tissue will degrade, and microneurotropins actually are very important in almost all neurodegenerative diseases. So we have synthesized, our group synthesized a small molecule which induces human stem cell proliferation and differentiation towards neurons. And we have the ambition, Mano, in the coming years, I don't know how many years it will take, to try to replace what a brain suffering from Alzheimer's disease loses with fresh tissue. In other words, we advanced the theory, not only us, many people in our field, the neurogenesis theory. So we don't care how we lose cholinergic neurons within our cortex. We are ready, by using conventional pharmacological approaches, by giving drugs that enter into our brain, to produce de novo, fresh, normal cholinergic neurons and replace what is happening in the disease. So we will have the ability to prolong the quality of life for these patients and make neurodegenerative diseases a chronic disease, as actually, Manos, is the case, and it's very provocative for us, for me at least, you are younger, for cancer. I will state today a very provocative statement. Cancer, guys, will be a chronic disease within the next 5 to 7 years. When I was a student, 25% of people with cancer surviving after 5 years. You know, what is the percentile now? 78%. And in the coming 5 to 7 years, this percentile will reach 90%. Cancer will be as another degenerative disease, hypertension or heart conditions or problems within our blood. So cancer will become a controllable disease. And we do hope with these technologies to translate these extreme techniques also in neurodegenerative diseases. This is the organ on chip that we mimicked substantia nigra and Parkinson. Now this chip is used in many labs in the US and in Crete to develop new medicines for Parkinson's disease, and for people that are neurologists, they know very well that we have very few medicines to help people. And the most important, guys, I'm sure that you will discuss it in pharmacology, L-DOPA helps for some years the patients, but after some years later, it becomes neurotoxic and accelerates the disease, which is very detrimental for the patients. So we have this type of chips now to see Parkinson's disease in a completely different way and try to develop drugs not in animal models, but also in a human pattern. This is the last chip we have done with a very talented, actually, PhD student of mine, Antonio Varone, an Italian. We prepared a chip to simulate human lung. So not only we prepared a chip that is static, you have all the components of human lung, fibroblasts, alveoli, epithelial cells, but this small chip behaves as our lung behaves. It extends and closes, and we have two pumps that mimic what is happening in our thorax. So you have diminution of the volume and increase of the volume, and this is happening in a human, actually, platform. And now we use this, we started using this chip to develop new drugs, for instance, for COVID-19 disease, and we have some of them, not antivirals, but try to help the people that escape from the antiviral therapy with very damaged, deeply damaged lung. So we try to develop medicines for these people and try to reverse the damage in these people. And we have some very interesting, actually, results. I will urge you to get this review article, recent review article of my boss, Don Egber, a professor of Don Egber. Don started his studies in New York as an architect. Then he went to the medical school. He became a pediatrician, afterwards a pediatric surgery, and he abandoned all this, Mano, to develop this institute and develop this type of technology. So he wrote a very interesting review article, and I will urge you to read it. And this article shows that it's not only the cases I presented today, briefly, in terms of organs on a chip, human organs on a chip. We have different types of organs on a chip: liver, kidney, uterus, eye, brain, of course, which is my field. So the situation becomes very interesting for the coming years. And now we advance in the second stage. We try to do multi-organs on chip. So we combine liver with the intestine. We combine liver and vessels with the heart. So we start to simulate not only a single organ, but a physiological system. And this, it may be the future, 3 to 5 years later, we can have a humanoid chip for clinical trials. Imagine the situation. You have on the same chip the liver with the metabolism, the kidney with the excretion, the heart, the vessels, the uterus, and the brain. And this is the future, and this will shape in a different way how we will develop medicines in the coming 5 to 10 years. And I will finish by showing you the real players of all what I've presented. I was very privileged to have very good students, PhD students, not so many. For the 35 years, I had 12 only. 10 of them are professors, very few in Greece, in MIT, in Harvard, in London, and I'm very proud of these guys. They shaped my academic career and path, and I was feeling very privileged to have them with me. And the last message I want to give you, you have chosen a wonderful, extraordinary science, not only in terms of human beings, but also in terms of technology. And if you like really technology, if you are a computer or a technology geek, as I am, you will have a very interesting life. Thank you so much for this invitation. No questions. Right, okay.
You can say that. We can skip it, thank you. Skip it, thank you.
All right. Ladies and gentlemen, that concludes the opening ceremony of CAMeSM 2023. Thank you all for joining us, and we hope you had a wonderful time at the conference. You're welcome to join us later for wine and cheese. Hope to see you there, and have a nice evening. Thank you so much.
Thank you. It's at the cafeteria, the wine and cheese.
My hearing is stressed.